the Believers Church, Medical College in Kerala, and Gokhel Memorial Girls College. These are the three organizations. Swami Vivekananda, I have mentioned, University in West Bengal. So these are the people who already have memorandum of understanding with Navajatak Child Development Center. So I would wait for Megha's introduction and Megha's comments about today's meeting. This is a continuing medical education series meeting that we are going to start. Over to you, Megha.
Thank you so much. So yes, we are live on Facebook as well, because post 100 participants, you will be directly connected to the Facebook.
We just missed out on the number of participants, Megha. What was that?
Everyone,
Oh dear, your
I'm
connection is
sharing
breaking.
my screen. Just
Okay. Just be mindful that connection is not stable.
276. Okay. Thank you. I hope my screen is visible.
Yes, it is visible, madam. Blessed known to every distinguished speaker and inquisitiveness scholar.
Thank you so much. So, hello everyone. A very good afternoon. I am Megha Goenka, moderator for this today's CME. It's my privilege to welcome you all to the CME on ICF, International Classification of Functioning, Disability and Health. So it's going to be almost 4 hours long CME. So for the smooth ongoing, I would like to lay few guidelines. So can you all see the second slide?
The first slide is only visible, please.
Okay, thank you. Just give me a second. Stop share.
Audio.
Is my slide visible now?
The
No.
presentation is not visible, Megha.
Okay, thank you.
Oh, this technical glitches.
Never depend on.
Yes, we're so dependent on that, right?
So I'm sharing my screen again. Just let me know if you all can see the slides.
Yeah, all the slides are visible.
My second slides?
Yes, it is.
Yeah, perfect.
Yeah,
So
yeah.
as I welcomed you all, I am again going to do that. Welcome everyone. And as it's going to be a 4 hour long CME, I'm going and we hope it goes smooth. So I want to lay few guidelines so that it goes. So the first rule is make sure your audio is connected so that you can hear us well. And kindly keep your audios on mute. Just check your audios and just keep on mute so that it avoids any disturbance. And, we would appreciate, is someone speaking?
We are seeing that Nishant Kumar is speaking with his camera on.
Mr. Nishant?
सबको information चला गया है कि document verification है।
Utkarsh, you can just mute him. You have the rights.
Okay, ma'am. Done. Done. No.
From my end as well, but
Yeah, you are on, Mega.
yeah, I am on, but some Murphy's law has taken place again. So I'll just check. Just give me a second, everyone. I'm so sorry. Yeah, is it visible now?
Yes, it is.
Finally, thank you, Shubhangi. So yeah, the few guidelines to make our CME smooth is first, please make sure that your audio is connected. Second, please keep your audio on mute to avoid any disturbance. And we would appreciate if you can switch on your videos for better communication and connect. And yes, we all would love to see each other. And during session, if you want to ask any questions or put forward any comment, kindly drop it in the chat box. We will consider that and discuss it at the end of that particular talk. For any technical assistance, we have Mr. Utkarsh Singh with us today. So if you face any difficulty, you can either drop him a chat or you can drop a chat to me as well. And in the chat, Utkarsh is going to drop a WhatsApp group link. Many of you are already a part of it. And the ones who are not the part of it, kindly join. We might post few materials for reference during post or during the session. And my main concern for the WhatsApp group is yes, for the Murphy's Law, if anything happens, so we can just quickly connect over that WhatsApp group. So I'll move forward. I hope all the guidelines are clear. So now I would like to move forward and introduce our convener for the CME, none other than Dr. Anjan Bhattacharya. Dr. Bhattacharya is a senior consultant developmental pediatrician and head of Department at Child Development Center, Apollo Multispecialty Hospitals, Kolkata. He has set up India's first CDC in corporate healthcare. He is one of the WHO expert for ICF course sets in pediatrics. He is a board member of Royal College exams for MRCPCH UK and DCH UK. He is the director of the course Postgraduate Diploma in Early Intervention for Neurodevelopmental Disorder, which is a state university affiliated diploma program. And he is director of Navajatak Child Development Center, Kolkata. I would request Dr. Bhattacharya to kindly take over.
Megha, thanks for fantastic introduction and taking care of the glitches, setting the rules so nicely. And it's actually nice to see faces, but if you face any technical difficulty like bandwidth issue, then we might have to take the videos off, but we'll see. So what is the background of this CME, Continuing Medical Education lecture? Why are we doing it, and why are we doing it for such a long period today? To hear about that, I think I would like to refer to a story that Megha told me about Dr. Elizabeth from Believers Church Hospital, Kerala. And I would really like to hand it over to Megha. And with between her and Dr. Elizabeth, I think if you chat about your story, I think we'll have a context of why we are doing this CME today. So over to you, Megha.
Thank you, sir. So before we move forward, I would like to then introduce Dr. Elizabeth. And for that, I'll just share my screen again. And yeah. Okay, so by that time, I am trying to reshare my screen. It is like putting me in a difficult situation today. But anyways, I'll start introducing Dr. Elizabeth. So Dr. Elizabeth is a senior consultant pediatrician at Sneha Dharma Child Development Center, Believers Church Medical College and Hospital since the year 2014. She is an alumni of Coimbatore Medical College and Stanley Medical College. Her past affiliations are Sultan Qaboos University Hospital, Oman, PSG Institute Medical College, and Father Muller Medical College. She holds a life membership of Indian Academy of Pediatrics. And her ever-learning fervor has recently made her join the Stanford DPB Mini Fellowship ECO to support children with developmental issues. And yeah, so ma'am, can you please, yeah, ma'am is already here. Ma'am, can you just switch your audio on and video too? And share your experience and Stanford that I already know and we have discussed it over a call.
And what about that slide?
I'm trying.
Megha, you can do it from that multiple sharing setting.
Elizabeth ma'am, you have to unmute yourself first. So the technical guy is helping ma'am.
Yeah, ma'am, sharing this.
So my slides are on. And this is ma'am at Stanford.
Okay.
I think there is some technical glitch.
I do this. What are you doing?
Okay, give me 2 seconds, I'll just check.
Hello.
Yes, we can hear you now, ma'am.
Okay, now I'm actually using my phone. Now, my first slide, which I'm putting, now actually I went for a holiday to US, and there the Stanford University was close to the place where I stayed. So I went to the Department of Behavior Pediatrics and met the head of the department. And she was very happy to share with me the fellowship, which is being called the Extension for Community Healthcare Outcomes. So we were all talking about the same thing. We have patients who are living very far away from the center, and patients have difficulty reaching the center. So they have a system where the patients are seen over the digital platform. So that's how I started this session with the Stanford people, and it's going to be for some time. Back home, I'm already working in the place called the Snehadram, which is a child development center at Believers Church Medical College Hospital. Now, we all know as the child's brain and behavior makes up most of who they are going to be and how they experience the world based on the first 1,000 days. If you look at the slide, I'm very fond of the slide, which shows that the synapse formation in the first 3 months, 6 months gradually becomes a peak at about 2 years. And further on, it starts what is called synaptic pruning. So each child, though they are in the same family, they grow up in different ways. So this is the basis of what is called the tabula rasa. Now, this is the knowledge for the child comes from experiencing or perception through their special senses. And every child is very unique because their biological, their psychological, and social environment is different. If you look at the peas, the Pisum sativum, we all are similar to that. So every gene may be the same, but the environment makes a lot of difference, which I think the speakers are going to talk to you. So as a result, there is a lot of difference when you name a person healthy or disabled. So the WHO has started what is called the International Classification of Functioning based on the ability of a person to interact and be able to function in the environment or the family they grow up. Today, there is a paradigm shift from the medical approach to an approach called the biopsychosocial approach. What I mean by that is different people approach the rehabilitation place. Some people use a research place, and the doctors still have the clinical settings worldwide. But however, we are talking about the same child who grew up in a different environment, a very unique environment to the child. So there is a shift from the rehabilitation to what is called a holistic family-centered model instead of a medical center-based model. So there are a lot of multidisciplinary therapists who give service to a child, and this is given in their own home or the school. So for all these people who are doing the service of rehabilitation, research, or clinical setting, we all need one standard language. Through this language called the International Classification of Function, we get the conceptual basis for the definition of each disability. We are able to uniformly measure health or the disability. By classifying them, we give the disability a framework. How much a child is functioning and how much disability the person has is measured uniformly in a standardized way. And we are also able to measure what is called the restrictions in their participation and the limitations in activity. So I'm sure today's CME is going to be a fantastic one, which each part being given to different speakers. And I think we're all going to enjoy the next 4 hours. So every child is unique. Every child is very unique in his critical period, the first 1,000 days. And I welcome you to a very good, fantastic CME ahead of us. Thank you.
Thank you, ma'am. And because of this story that you shared with Megha, and Megha when came and talked to me about it, I said, okay, yeah, absolutely. Absolutely. If Stanford is making ICF its standard in assessment, I'm pretty sure we will do that in almost no time, right? So this is high time that we talk about how to use this tool in practical fields. But we need to know about this particular issue. What is ICF is something that we need to understand. To do so, we have to go back to the history. To invite two of our psychologists from of how things have started in different fields. So over to you, Megha.
Okay, so I would like to invite Miss Devika and Miss Shubhangi for the first talk of the day, which is on Bronfenbrenner's model. So by the time you both are sharing the screen, I would just like to give an overview. So we are going to know about ICF in detail definitely today. But before we do that, we are going to understand what Bronfenbrenner's ecological model is and which is into existence from way before then ICF was. And we psychologists study it in our textbooks. And yeah, so Miss Devika and Miss Shubhangi is going to make all of us understand. So over to both of you.
Is it visible?
It's not visible.
It was visible
It is
earlier.
visible. Yeah, now it's visible. Perfect.
So good afternoon, everyone. So today we will start with our first session, that is Bronfenbrenner ecological theory or model. So this is the overview we will cover. The first is what is ecosystem and ecology, nature versus nurture, and the history of this model, introduction to the ecological model, and there are some components of environment and the different levels in this system. So first, what is ecosystem? So an ecosystem is a community of living organisms. For example, there are planets, animals, and microorganisms that interacting with each other and their non-living environment, which is abiotic, such as air, water, minerals, soil. There are some specific area in the geographic settings. So next, what is ecology? So basically, ecology is a study of ecosystem that we will learn about. Next is nature versus nurture. Okay. I'm sorry. Okay. So nature versus nurture. As we all know, for over a century, there been a debate about the extent to which genetics or external influence in child development occurs. So for nature, it means that our genetic component that we inherit from our ancestors, that is within us. And nurture means the environment that we are exposing to after the birth and how that influence in our development holistically. So now we will move on to a little bit biography about Bronfenbrenner. So he was a Russian American psychologist and he completed his PhD in developmental psychology from the University of Michigan in 1942. His father, who was a neuropathologist, often pointed out the interdependence between living organisms and their surroundings, how they interacted between each other. And from this, he sparked his interest to further explore the theories in ecology. And from there, he coined this term, the ecological model, that also known as the bioecological system theory, which describes that components' own biological makeup that impacts as a key factors in a child's whole development. In 1979, in his book, he first wrote The Ecology of Human Development Experiments by Nature and Design. From there, he started expanding his theory about the nature versus nurture interaction. Excuse me. Hello. Am I audible?
Yes, Devika, you are.
Okay. Now we will see some components in the environment. There are 4 main components in the environment, that is person. Person means the individual, his personality, physical appearance, his race, culture, everything, including his unique capacity. Context means the space they are living. It could be home, school, peer group, community. And the time the changes occur over a period of time, that is historical changes or any pandemic changes. And processes means the interaction with the objects, means the living and non-living interaction in the environment. Now we will see a video. Okay, let me play.
Bronfenbrenner's ecological system theory conceives that a child is influenced by 5 ecological forces. First comes the microsystem of family and friends that affect the child directly. Second are the forces of the connections between the people around the child, parents with teachers and teachers with peers. Then there are links between social settings that do not directly involve the child, such as the father with his boss, the peers with their parents, and the teacher with the principal. Next is the overarching culture, religion, and social norms that influences all others. And lastly, there is time, which changes everything over the course of one's life. Children are born into a microsystem that influences the child's experiences directly. Children from unfortunate backgrounds are more likely to experience problematic family structures, even if it's simply for the fact that parenting is more difficult if you are poor. They also encounter more negative situations at school or bad influences through friends. Consequently, a child that grows up in a negative microsystem will find it hard to succeed. The mesosystem represents the interconnections between the elements that surround the child. For example, the relationship between the father and the school teachers. If the father doesn't get along with a teacher, the child might suffer. The exosystem involves the links between social settings that do not involve the child. For example, a child's experience at home can be influenced by their parents' experiences at work. If the mother loses her job, there might be more arguments with the father, resulting in changes in their interaction with the child. The macrosystem describes the overarching culture that influences all other systems, such as a child's geographic location and ethnicity. Intelligent people who happen to live in bad places are more likely to move to better ones, but that also means that they are more likely to be strangers in a richer society. So, regardless of the child's biological potential or upbringing, on a macro level, he or she may still be at a disadvantage. The chronosystem refers to changes in the child and the environment over time. As the child grows up, the parents may stop loving each other and divorce, which can be traumatic for an 8-year-old boy. 5 years later, he may have come to terms with how things turned out. But when the boy turns 16, his mom's new boyfriend moves into their tiny apartment, and things get difficult again. Bronfenbrenner, who was influenced by Lev Vygotsky and Kurt Lewin, convinced the US Congress that a child's prospect is not genetically predestined, but is the result of the larger environment they happen to be placed in. Children who grow up in unfortunate social structures, therefore, need a form of support that not only reaches their families, but also elements of their community. Bronfenbrenner's theory helped form the Head Start program in 1965.
So now I would request my dear fellow, Ms. Shubhangi, to continue the further discussion.
Hello, everyone. I hope I'm audible.
Yes, Shubhangi, you are.
Okay, thank you. So I would be continuing from Ms. Devika's learning points a little deeper into what the ecological model is about, based on the video we just watched. So if you look at the ecological model as a whole, you would find a great resemblance to Russian dolls, or like a cut portion of an onion from inside. Bronfenbrenner explained the child's environment or ecology in terms of concentric circles, which are like layers around a child's environment, which directly and indirectly prosper a child's growth and development. Moving on to the next slide, the first layer is the microsystem, which states the immediate environment of a child since birth. In a more Indian context, it is usually the parents of a child, the friends, and also the neighborhood with whom the child interacts with on a daily basis. these people have a direct and major influence on the child, and the child also influences in return, thus explaining the bidirectionality. The next layer, the mesosystem, which in simple terms explains the interaction within the microsystem. A very common example would be if a child's parents have a good relationship with the teacher, the child may feel supported and have a positive view of the school. However, if the relationship is not good, the child may not feel positive about school and may not apply themselves properly, right? So the exosystem, however, it refers to a more informal and formal institution base in which the extended environment provides an indirect influence on the child. These comprises like the local governments or the friends of families and relatives whom we do not interact on a regular basis, but they have an indirect influence on us. An example would be the occupation of a child's parents or the changes in parents' occupation, which are factors which do not directly influence the child, but major influence in shaping themselves. Now, coming to the macro system, it refers to a more invisible layer of a child, around a child, which are not directly seen, observed, or it can be, however, seen through behavioral aspects. Like, for example, one's cultural influences, a child's beliefs, a child's social norms, etc. These indirectly influence the child and how they behave in social and ecological context. For example, living in a society that highly values individual achievement. Okay, so in this case, the child might be encouraged to be more competent and self-reliant compared to a society which does not encourage such individual achievements. The final layer, called the chronosystem, explains the effect of time on a child. It involves like the historical events or the transitional aspects in the ecology. One major historical event in today's world which would be having a long time impact would be the COVID-19, which we have recently individually faced. So these 5 factors together form the ecological model, which explains the development of a child. Even though it explains all the social and biological aspect, it has a drawback of not focusing on the psychological aspect of an individual to the level it must. Thus, encompassing all aspects of a child, an ICF, which is a holistic family-centered model, like Dr. Elizabeth just mentioned, would help to assess a child beyond their immediate environment and biological limitations, which the other speakers would be speaking of in details. So this was about the Bronfenbrenner model.
Thank you, Devika. Thank you, Shubhangi.
Thank you.
I think we now have a little idea that, you know, when we talk about biopsychosocial, what kind of basis we are going to talk about. Now the question is, what are we going to do about it? I mean, how are you going to measure and all those things? So it's very interesting that, you know, I was in UK, London, and many of you might have heard the stories who have joined ICF training before. We used to hear as developmental pediatrician lot of complaints about, you know, the distance that patients will have to travel, the finances that they do not have, the number of family members that they have to take care of, the education that they don't have as they should. There are various factors which was actually affecting our treatment as medical people. And in 2001, I was in London, borough of Newham, where my consultant at the time gave us something that has been distributed countrywide. It's called ICF. And that is the time, 2001, when WHO actually created this ICF endeavor. And it looked like it is a complete solution. Now, I'm not going to talk to you about all those solutions. We'll talk to you about later on what we do here. But before that, let's have some international perspective from Lisbeth Siderius is another developmental pediatrician practicing in Netherlands and deals with the rare diseases organization there, and is has been a president, I think, of the European Pediatric Society and all that. So we will have a perspective, because Lisbeth works deeply with India using the ICF, and not just ICF, it's the whole digital. Dr. Elizabeth has mentioned about this digital health model. So Lisbeth is going to tell us about the digital health, what they are doing over there, and the ICF in the middle of all these things, and how we can do things in India, something that she herself has done. So again, it's over to you, Megha, to introduce Lisbeth properly, so that we can hear from Lisbeth about what latest things that she is doing. Where are our frontiers?
Sure. So, okay. So I would introduce Dr. Lisbeth directly. Dr. Lisbeth is a consultant pediatrician from Netherlands. She is trained in pediatrics and genetics, and she has experience in hospital pediatrics, academic genetics, and preventative child healthcare in Netherlands. As a volunteer for patient organizations, she advocates for their crucial role, believing in digital tools to empower patients and improve communication with healthcare providers. She also aims to help develop a global child healthcare network that definitely ensures that no child is left behind. And yeah, so from there we got our topic, leave no child behind, and digital health. Over to you, Dr. Lisbeth.
Okay, can you hear me? Do you all
Yes,
hear
we
me?
can. Yeah.
You see the screen?
Yes, we can see the screen, the first slide.
Okay, I'll try to move on.
Definitely.
हम देख लेते हैं उसको इससे क्यों लेके आए हो
So thank you for inviting me in this very interesting course. And thank you also to have been possible to have some views in India in 2020. So I learned a lot in how you are doing in Kolkata. So and it takes me also further to try to collaborate worldwide on digital health. And I think India is also doing very good at this subject. So I hope the screen, yes. So many children are left behind. I have been in Georgia, Tbilisi, Georgia, where in the hospital children were left behind. People could not care of them, and also government didn't care of them. So there is still a lot of neglect of the child's rights and the rights of the disabled persons because a lack of data, a lack of diagnosis. In Europe, we are following the European Union, and they made a regulation that all patients, all individuals have the right to have their own data in a structured, common use and machine readable form. So that makes us as professionals also be aware of these laws and also this whole global movement, because this is not only in Europe. As I said, it's also going on in India, probably faster maybe than in Europe. So this was already a directive in 2016. And then in May 2021, a new directive was announced, and this year it was adopted by the European Union, that there should be electronic records should be able to talk to each other. So if you work in Kolkata and I work in the Netherlands, our computers should have the same language beneath. We don't exactly have to know, but still, so that we can exchange that in exactly the same manner. And then we use computer language, not written language as we usually do. So this makes it all in progress, a lot of progress, especially in Europe, because every country now has to do the same. So, Europe has many different countries, many different languages, many different health systems. Still, all these countries have to do this. And that is now going on. And the ICF is right in place because it's also a coding system which can exchange data from one electronic system to the other. I'll explain about that. So already more than 10 years, we from Shwachman-Diamond syndrome. Shwachman-Diamond syndrome is a rare condition, recessive, so both parents are carrier and can have children 1 in 4 with this very complicated disease. And all these children first are born and then go to primary care screening and development screening, growth screening, and then they have a diagnosis, and then they have a guideline. This guideline is applicable to that diagnosis, but then they also have these disabilities. And then we use, as you see in this circle, the ICF. So ideally, if we could follow this lifetime circle, real life circle, we could see when the child would first be diagnosed, what diagnostic features have been made the diagnosis, and then also how the child is doing in real life. And that is why ICF is very important, also because of this community and social more getting interested worldwide. So you see the ICF in the round at the right side. You see also ISO 999, that is a coding for aids, for example, wheelchair and so on. That is, so on the right, left, on the right, on the bottom, you see where we are discussing now. But before the child gets there, you have to have some diagnostic features. So also at the same time, WHO has produced a booklet, Primary Healthcare for Children and Adolescents. And it also includes disabilities. And this booklet describes how WHO Europe wants us to work in primary care. And we have looking at this and have been looking how to digitalize this booklet. This year, the booklet is available on an app. Very, very nice, because you can have it in your practice easily on your phone. It's free. So we took some examples from the WHO, some illustrated cases from the WHO booklet, and describe how we can make this with the digital terminologies, such as the ICF, into a system which can exchange the data, which is called HL7 or FHIR. You can forget the name, but that's the road where it goes on. And then we want to understand and talk about how we can make these standards exchangeable and which standards we use for what. That is the most important. So interoperability of data in primary care, and we have to search for the correct data terminologies. And therefore we use the ICD, as already mentioned, the ICF, and we have also chosen laboratory coding. It's very helpful. So for example, here you see different coding systems, international applicable. Also you see the ICF, but you see also the LOINC, which is for laboratory tests. And you see an example of a child with this morphology. And then we see the different codings where they can place. So this is an example, easy for us all to understand. Everyone is measuring the length of a child. I presume also developmental pediatricians, because it's also very important to know the length when you see a child and the growth. So for that we use the LOINC coding. So this is an example of a coding number, and then you can fill in the value in centimeters or inches. This I tell you all because to understand why and how the ICF is in this whole digital system and why it's very important. So also WHO thinks we all should use digital health systems. So to approve. So we as pediatricians, we want also the data from before birth. Has the mother taken alcohol? How is the social situation? All these data. And during pregnancy, we want all these data. So this is all already what we want to have in our electronic record. All possible with codings. You don't have to know exactly, you just have to know it is possible, and we are working on it. So real-time evidence is the code monitoring. It's easy, as I showed you. We can use the LOINC, and this is how it is described in this primary healthcare booklet. So this is an example of how we can use these codings. We use an example in Sri Lanka. The mother has achondroplasia, and then she has ultrasound, and we see that the child has a short femur, and this child is also has achondroplasia, and then we follow the child when it's born, and here you see an example of this digital language. You don't have to know and remember, but you just have to know this is in your computer. This is how what we put in can be translated in computer language. So in this case of the mother with the child, we just a few examples how these data can be exchanged. So in this way, we can collect real life data. Very important. Another, on the right, you see I'm in Kolkata in 2020. I visited a house for developmental delayed boys. It was very interested to know and see how this is working, very well taken care of, and all very active. So on the left side, you see the list of diseases which are in the booklet. And you also see 7.3 is autism spectrum disorder. This is another example from thalassemia, just to show you how it works. At vaccination, you can see a child and you see this abnormalities, large spleen or anemia. And then we also make translation in digital language, just as an example. And this is important, of course, thalassemia, because it's very occurs mostly in certain areas. Then we go to another example. Of course, a child is born, or when you see it at the first time in your clinic, in the primary care clinic, we see skin disorders. So these skin disorders are sometimes the first sign of a genetic disorder. So in this case, I want to show you a case of tuberous sclerosis spectrum, which has deep pigmentation, you see on the right. And then we can all code this in with a certain coding system, HP. Also, computer readable system. So when finally diagnosis is made, we will have this person also have a high chance of autistic spectrum disorder, but it will be specifically for this genetic defect. It will not be the common autism. It will be specified for the genetic defect. And that is why, as already mentioned, the medical findings should be combined with the social findings, the ICF findings. What are these people able to do, and how can we help them? So as Shwachman-Diamond syndrome, which I represent, who pay me, that's more also an important part. So these children have failure to thrive, they have fatty stool, and then they have pancreas insufficiency. And later they are diagnosed, usually by a genetic test, to have Shwachman-Diamond syndrome. So these people we meet every year, and family meet, and I hear their problems. One of their most serious problems is their little disability. They can work, yes, and they can drive cars, but all needs a little help. And what was their problem? They want to work, they don't want to be ill, they want to participate, and so they are very, very tired to do at the end of the day or in the weekend. So their biggest problem is they're tired and they cannot participate in recreation and leisure. So this is also why, as doctors, we maybe not think, at least I didn't, that this would be a big problem for them. So I learned a lot by knowing the ICF codings from a small group of people. This is adults with Shwachman-Diamond syndrome. It also more or less illustrates that the doctors usually do not know enough about these social issues, and vice versa. I mean, you also have to know a little bit on the specific genetic diagnosis if you deal with ICF. So this is then a case of the ICF coding. It's D920 when it comes to recreation, and then we can code it 0 to 4. So when I was in Kolkata, we also visited this Disabled for Children Center. Very nice, and learned a lot. So there, I saw this grandmother taking care of her grandson, and she had a cell phone. So in fact, you can reach everyone with your ICF, because all these ICFs can be transported far away if you have a cell phone Wi-Fi. So this is an illustration of this ISO 999, a father of a child with ring chromosome 20. He has many epileptic seizures, and then at that time he doesn't learn. So his father developed this sort of EEG. So the light goes on, red light, when he has his seizure, and the teacher knows that he's absent, has absence. Very nice. It's EpiHunter, specifically for this rare disease, chromosome 20. So parents can also help and develop new things. So just a little bit that also in the European Commission, they have said we have to use the ICF when it comes to disabilities. So that is helpful to make our way through more regular function use of the ICF. And this is a little illustration of how this FHIR, what this FHIR is. We can make APIs, which is a computer exchange program. And so in fact, we can make evidence-based guidelines, get clinical data points and terminologies such as the ICF, and translate in digital language such as JSON. And then we can all make a computer able to communicate through this sort of, for many people, secret language. But it shouldn't be secret. We have to know and understand. So that is how we can come from mother-child healthcare and growth and development to computable guidelines and immunization and social support all together, the ICF used in social support. So this is our model. We have published this last year. And I thank you all. I thank my colleagues in India for letting me know more and understand more about you and how it's working. And I think now at this time, also India is working very nicely and progressing on this internet exchange. So at the moment, I was in Geneva in May, and we are collaborating now with Europe-India group, which go for data first, AI later. And that's the newest development. And I hope I can still collaborate with you. And it's very important. Everyone has to know about data exchange.
Thank you, Elizabeth. That's fabulous. And I think, this is a thing that probably a lot of the people who would understand digital health and would understand ICF, they will know that. But I wanted them to have a feel of how the world of health is moving. And because you have mentioned so much about, the work that is going on in India, it would be completely unfair if we don't mention Dr. Gurpreet Binapal and our ICF group here in India, who are doing one ton of job. And we have recently through ICF Education Group managed to publish our guideline, consensus guideline. So that is fantastic. So I would like to thank you. I would request you to stay within this question and answer session that will happen later after Jewel Chakraborty has shown us. And congratulations to Jewel. He has recently completed his PhD as well. So we'll see him show how exactly we do it in real life. But before that, I think we would really like to know about the wonderful work that Gurpreet and his colleagues are doing in Mohali and other places. And Gurpreet used to work in Canada before coming back to India. So welcome back, Gurpreet. That's a thing. We have a small club of people who have come back and trying to do things. And ICF is one of those things we really want to do because it's a integrative model. and it's supported by WHO. So I would again invite Megha to introduce Gurpreet properly. And thank you so much, Elizabeth, for your ready participation. Thank you. And nice to see you after such a long time. And it's Tbilisi probably where we met, isn't it?
Slovenia.
Slovenia, we all met together, but I met Elizabeth in Tbilisi.
Tbilisi for the
Yeah,
first time.
yeah. We met again in Slovenia.
Okay, Megha.
Thank you, Dr. Elizabeth, for your talk. So now we'll move ahead with Dr. Gurupreet's talk. So Dr. Gurupreet is a retired district program officer with specialization in MD, chest and TB. His pioneer efforts has made in many domains like autism care, tobacco control, and tuberculosis research. With many of his key achievements, few includes establishment of India's first public autism center and recognized research in TB screening, which has significantly contributed to public health. And and for that, and his many of the works, he has received numerous awards and honors, and continue to advocate for disability awareness and WHO ICF implementation. So over to you, sir. Dr. Gurupreet. You can share your screen. Yes. Yes. We can see you.
Hi, how are you?
I'm fine. How are you?
I'm good and nice to be here with all of you. And thank you for giving me this opportunity. Dr. Anjan, your team, I can see Dr. Elizabeth also, and all other members, right? Thank you so much for this opportunity.
Thank you. So we are pleasure to have you here.
So I'll begin with.
Yes, you can share your slides.
Okay, can you see it?
Yes.
Right. Okay. So thank you once again. And it's nice to be joining here for this wonderful CME organized by the CDC Kolkata and all the, the partners. So my topic I have been given is for the consensus statement on ICF. So I would begin with the first slide, which is my inspiration for ICF basically. And that is, my son who is on the autism spectrum. And so we see our autism from the point of view of, deficits, but after, coming in contact with people who are advocating for ICF, I realized that, there's much more beyond just the deficits which we consider. So it's more about the functioning aspect which we have to consider. And that's how, I have come into ICF. This center at Mohali is the first of its kind in India. I know and I'm aware of the center at Kolkata, which is a partnership between the West Bengal government and the Ratnavali group. So it was there in 2018. The foundation stone for that center was laid. Indian Autism Center, I suppose you call that. So this one is the center at Mohali. And you can see the 3 blocks here. One is for the diagnosis part, the middle one. The other is for the school, the one on the left. And the one on the right is for the parent caregiver training. So basically, this is the model. And this is how, we are talking about the environmental aspects of a child who is suffering from autism or maybe from neurodevelopmental disorders, that you got to consider in totality, not just the middle block, the diagnosis, but the environment that is on the right and the left, that is the parents, the family, the caregivers, the school, and, it's the school and the vocational center. So overall things you have to consider when you think about the child with developmental disorders, or any other child with any other deficits. So that's the concept. Okay, the second thing is I wanted to bring, we all are aware about what is health. So what we have been taught during our MBBS years is that health is, a state of complete physical, mental, and social well-being, right? First, it used to be defined as, absence of disease or infirmity. But then the definition was modified as a state of complete physical, mental, and social well-being. So when we talk about all this, combined definition, we are thinking about improving the deficits and also the improving the environment of the person who is having any disability. So then there was another thought that is about the human rights aspect. So it was realized that it's not just, the deficits and the health of a person which matters. It's the environment which has to be taken into consideration. So not just the physical and mental health, but the social well-being. So that's how this whole concept, the environment coming into picture is there. The person should be able to lead a life without limitation or restriction. A person is disabled not because of his own capacities. Even the addition of the environment makes a lot of difference. So it's the environment which makes a person disabled. Person as such may not, may be able to do much more than what he gets because of the restrictions, the barriers, what we call. Disability definition, it's an umbrella term, and it includes the impairments. So that is the body, from the body aspects, and activity limitations and participation limitations. So together, we are considering the holistic approach for a disabled child. Impairment just for body function, activity limitation is about the individual. He's not able to perform a task, and participation restriction is because of the involvement in a life situation. So the whole umbrella of, this thing, the individual in consideration with his environment and other aspects, that interaction leads to his being disabled or being abled. And in overall, 600 million people across the globe are living with disability. Based on this, there was a model disability survey conducted by WHO and the World Bank, and a joint disability report came up in 2012, under which, it was realized that you should have a proper data that needs to be collected, and this data should be comparable between the nations. In addition, the United Nations Convention that has also asked for, that the states who are the signatories, they should collect appropriate information, statistical and research data, so that they can formulate policies. So I'm talking about this because when we talk about further what framework which we are going to adopt, it is just to collect a good data which will enable the countries to formulate their policies and give services to the individuals. So based on that report, then WHO asked the countries to formulate, a plan. So that was a plan between 2014 to 2021. And it was to remove the barriers, to improve the access to the health service programs, to strengthen rehabilitation, and provide assistive devices, support services, community-based rehabilitation, and all that. So under that plan. Then we have this WHO FIC, a word about this, that there's a family of international classification. FIC is Family of International Classification. We have three subgroups under this. One is the ICD, which we all are familiar with. ICD relates to the health conditions. We capture the morbidity and mortality data under that. Then you have WHO ICF, which we are talking about, and this will capture all the functioning data of an individual. And then there's WHO ICHI, which is related to the health intervention. So all these three come under the family of international classification. And based on this, it was also realized that functioning should be taken as a third indicator in the health system. And it's a key indicator for rehabilitation. This was a study conducted in 2017 by Gerald Stuckey and Bakenbach. And based on this, it has been realized that functioning should be taken as a third indicator in health system. Next is ICF consensus statement. That is my topic basically. And we had a meeting at Mohali in February 2024, realizing the importance of ICF, realizing the importance of this biopsychosocial framework, and the ability of ICF to enhance the description of health conditions, that ICF provides a right-based model. It shifts from, charity. Disability is not a charity thing, but it's more of a right-based consideration, which we are talking about. So WHO ICF is something which we all need to adopt. And we had this consensus statement wherein we had people from all over the globe participating for ICF. So what we did was that, sorry. Okay. So in that statement, we have mentioned ICF provides a standardized language and conceptual framework, which facilitates communication between the professional researchers and policymakers and general public. And it is important for formulation of policies and implementation of rehabilitation strategies. So whatever rehabilitation we find work which is going on can become more, you can deliver services to people who may be requiring the services but are still not able to avail it because they have not been, the data has not been properly captured. So this, based on the standardized language, we are able to capture that data and formulate policies. That was our first, consideration in this statement. So this was the agenda. Primarily, we had focused on two things because autism, as I told you, is something I'm passionate about. And my background is as a respirologist. So I'm also, interested in pulmonary rehabilitation. So these were the topics we, took as an examples. But the overall consideration was on ICF and data collection. So the purpose of the meeting was to build up an ICF application. Number one. Number two was to encourage research in ICF. So as you would find later in the statements, we have also mentioned that, without research, we cannot generate the data, proper data, and we cannot have, evidence-based approach. So we need to encourage research in ICF. Then, of course, the data collection in the health management system. This will be, in addition to the ICD-based data which we collect in these systems, the codes which we used. And then whatever data gets collected, this informs the disability policy so that the government can accordingly make, policies for the disabled. So we, built upon our progress, which we had achieved during our earlier conferences in November. And then the key focus of discussion was, as I mentioned, was on basically on autism and on pulmonary rehabilitation. We were able to publish 4 chapters on ICF, and in this NatCon conference, these were presented. NatCon is the TB and chest disease conference. And this was held at Mulana in Haryana in 2022. And then the publication came out in 2023, the chest compendium. I would also like to draw your attention towards the toolkit, the Rehabilitation 2030 toolkit. We gave, we did mention about autism and pulmonary rehabilitation, which are important components of this Rehabilitation 2030 toolkit of the WHO. We discussed about the Kolkata Child Developmental Model and Smart Start Hubs, which are functioning in Ontario. And these are examples of ICF applications. So we need to know that ICF is being applied globally and in India at your center. So that is something which has to be now replicated to other areas which have, where it is underrepresented till date. And we should be realizing this, that ICF is something which has to be incorporated in our systems and which forms the basis of rehabilitation. So promoting ICF-based research was an aspect which we discussed. We have already introduced, this research on pulmonary rehabilitation at Maulana. The GRID institution in at Chandigarh, they are probably coming out with a paper on ICF application in autism. They were doing ICF application in mental health, and this has to involve multiple sectors. ICF can be applied at micro level, meso level, and macro level. And by that, I mean that, at an individual level to plan his rehabilitation, meso level at the institutional levels to bring about the changes in the institution, policy changes, quality control changes. Macro level will, of course, be at the national level, the policy makers, and at the global level. So this is how, the common language can be replicated at all 3 levels and across all disciplines. So multidisciplinary approach, you have a common language, and that is the advantage. So scholars from all over the world took part in this, and we discussed on having a sustainable model of collaboration. And then we also realized the advantages of implementing ICF as a health indicator. As I already mentioned, that it should be included as the 3rd indicator for health based on that functioning approach, because functioning is the core of rehabilitation. So already I mentioned that the common language at all the 3 levels, micro, meso, and macro levels. And we are having, ongoing efforts to get this ICF, to create awareness about ICF, to create awareness about the research, to create awareness about its application in, the clinical rehabilitations. And then there are applications across the globe, and people from all over the globe participated in this meeting which we had. People from America, we had participants from Brazil, we had from Australia, we had from South Africa, Europe, we had Elizabeth, and then Southeast Asia, all over. So, and then we felt the need that there is a need for replicating it. Okay, so what is the use of this ICF? It is that, the data which gets generated will ultimately be monitoring the progress towards the sustained developmental goals of 2030, and especially the SDG 3 goal. And also monitoring by the United Nations, this right to persons with disabilities whatever the resolutions that have been passed by them. So this was an aspect which was discussed, that the Health Data Space Directive of the European Union, they have mentioned that there are two key uses of the health data. First, its use in the health service, and secondary use for the research and policy making. So what I'm talking about is the data generated from ICF. Unless we do this research and we get this data, we will be nowhere. We won't be having, well-informed policy, robust data informing our policy. And then we should also note that the use of data, the secondary use of data, is not possible without its use in primary use in the health services. So unless we start using it, and I'm aware of the fact that even ICD implementation, that is so slow that even at the district levels in the HMIS systems, people are, slowly moving towards getting that incorporated. I don't know when we are going to have ICF. So it's better to start with the research part and, promote awareness as we are doing today and as we were doing at that time, we started it. So again, we said that ICF will be supporting the monitoring of this, the rights. And then we need to have ICF because of the aging populations and rise of the chronic diseases, because with that, what we are looking at is the functioning aspect. Chronic diseases, a disease, we have this acute management and we have the chronic management, but there's also this in-between period. And that is the time when you have to continuously monitor how the person is going, how his health is getting affected, how the person is developing. So all that requires incorporation of ICF, and it provides a beautiful framework to assess the rehabilitation need, plan services, and monitor the outcomes of rehabilitation. Rehabilitation 2030 should be the goal. And it has been said that rehabilitation should be incorporated in the health systems. And there's a historic resolution of WHO Assembly, which was passed in 2023, which mentioned that rehabilitation should form a part of every, planning which we make for the health systems. So, and not just at the tertiary levels, it should start at the primary care level itself. And then getting the system level rehabilitation data and functioning related information from use of ICF. So functioning, we realize, is the core of rehabilitation, and it should be incorporated in the HIMS as the third indicator. ICF is recommended to ensure comprehensive understanding of functioning and disability while emphasizing data, disaggregation by sex, age, disability, and other context relevant factors. And then compliance with data protection is also crucial to safeguard the privacy and enable the monitoring of rehabilitation. So all the countries are aware of this. We say the data is of a person is very important, is very sacred also. We have to ensure the protection and privacy of this data. So there are laws. And by having ICF, we have this common system, and this is how you can have a global exchange. We can have, full privacy also, and we have a common language also. The countries agree to exchange also. So we should have this common system for measure. It describes functioning as an important supplement to the diagnosis. The impact of the context is described through environmental factors. So I think in the previous, the speakers must have already mentioned about the framework of ICF, that is the biopsychosocial framework, wherein you have, the biological health and the lived health total. So biological health, which comprises of body structure functions, and the activities and participation. This together combines the the lived health experience of a person, and this is the biopsychosocial approach, along with the factors like the environmental factors and the personal factors. Environmental factors are have been studied, but personal factors are also coming up. So we have to have this complete biopsychosocial approach for any health condition to to have a holistic to impart holistic care to a person. And it was this thought that the health system should incorporate functioning as its as another indicator. These are the signatories. So we have Dr. Anjan Bhattacharya from CDC. We had the team from Mohali, from Australia. Catherine was there, from Brazil, from Netherlands, and from Finland. And then we had even from Canada and Denmark, and from Southeast Asia. So we had from Sri Lanka also, and South Africa. All of us together, we formulated this statement. This statement is available on the website of the ICF Education. I'll be coming to that as well. These were the research participants from the Department of Pulmonary Medicine who took part in this, and they also presented their thesis, the one which they are doing on ICF. These are the references. About the events, so the ICF part in North India, we already have ICF being utilized by your institution. We have Alakananda, her group. She's been advocating for almost a decade, more than a decade, about ICF. But in North India, it's like north of Delhi, it is not much heard of. So we introduced it starting from April 22. In this NatCon conference, we brought those 4 chapters, and then the ICF symposium, which we had in 2022. So this was the publication on in wherein we have those 4 chapters. And this is ICF Education's website, where you can get the consensus statement, which I'm talking about today. The whole statement is available on that site. This is the conference. One is the GRID. At GRID, we had the workshop. GRID is the Government Institute for Rehabilitation for Intellectual Disabilities. It's the regional center there at Chandigarh. And then we had at AIMS, on 30th, we had at GRID, and first we had at AIMS, Mohali, and all the speakers are there. We had Dr. Mohammed from WHO. He spoke about disability in that symposium. These are the participants, and today I'm participating, honored to be participating on your CME, on International Classification of Functioning and Health, in association with the Believers Church and Swami Vivekananda Institute. These are some of the clips, the Rehabilitation 2030 pack. This is available on WHO website, and I encourage everyone to have a look at this, though it's not entirely ICF based, but it gives you the idea about rehabilitation, and that the other one is about the resolution which was passed by WHO to adopt rehabilitation in the health systems. Remembering that, ICF is the classification which will capture rehabilitation. So strengthening rehabilitation is a must using ICF. And these are the areas under universal health coverage. So earlier we used to do about, the promotion, prevention, and treatment. We are doing that, but we never thought about rehabilitation and palliation. So these are the areas which have to be looked on. By 2030, at least everyone should realize that this should be the goal. And the resolution was EB 152, which was, adopted by the WHO. And I would also like to, share my experience. Recently, I took this course. This is about ICF STARS. It's called ICF STARS, and it's about standardized assessments and reporting of functioning information. So the whole purpose of this was that, for rehabilitation, we have different tools which the clinicians are adopting, so which are not uniform. So they have, conducted studies at the Swiss Institute, the Paraplegic Institute, and the study was on, spinal cord injury patients. Based on that, they found that, ICF could be a tool which has to be used for a standardized assessment and reporting. Firstly, for rehabilitation planning at individual level, then for quality assurance, it comes into play, and then for formulating policies. So they did a cohort study also based on ICF, and then formulation of policies. And then, comparing two scales with ICF. So basically, ICF was the common point, and there were two other scales, tools used for measurement. So ICF stars is basically, it tells how you can make standardized assessments and reporting of functioning information. They say that, you can use the other tools along with ICF for measuring of functioning information, and gradually, shift over to entirely tools using ICF. And then this is an interesting article which I found, and it's in the World Economic Forum, which says that, you redefine health, that will boost the economy. Human functioning is a new health assessment framework that encompasses biological health and the lived experience of the health, together contributing to the well-being. So health is one aspect, but well-being is a practical aspect, including the environment also. And this approach can promote the economy of well-being by creating a society made of healthy and thriving individuals. And next steps should be for integrating human functioning into public structures, include recognizing functioning as a major health indicator. I mentioned about the third indicator. So other than mortality and morbidity, and then setting up a new research field called human functioning science. So we already have functional medicine, but then, you have research field. So this is an interesting article, which I suggest everyone should have a look at. Thank you. The journey continues. Thank you so much.
Thank you, Dr. Gurpreet. Thank you very much for the amount of work you have done, and especially the work that is needed that you brought to India when you came back. And so openly, with everybody sharing the fact that you have a son with autism, and that gives us the courage to really advocate for people with impairments which we don't need to turn to disabilities. So you have just defined it in your own actions. And I would also like to thank you very much for putting Kolkata development model as one of the best practice models that India can adopt, and putting it in our official paper in the ICF consensus, and really highlighting this ICF based model on which you are working at the macro level. And we will show you today in our later presentations how we are doing it at the meso and micro level. So this is fantastic, and we really want to do this collaboration. You brought so many countries and so many global players together, and most of these people I know personally, and a lot of them we have communicated. Just like you, I have never met you personally, but we have continuously communicated over the last few years. This kind of work is exactly what this world needs today. This is a divisive world we are falling into today, but that is not going to stand. With our group, we have now shared a video that I would want Megha to put into our WhatsApp group at some point, where it shows that the evolution has always rewarded friendship, means working together, means this integrative model. We need to do this integrative model for our own survival, for the survival of our race. And we need to include everybody in this journey. We don't discriminate between who they are and what condition they are born with. So you are fantastically put that into words, and your one ton of work, if you look at the spread of his work, I mean, you know who is speaking, and it's so nice for you to agree to come and do this. I really miss that November last year meeting, because my father was unwell and I couldn't be there. It's a all defining photograph for India, I think, for ICF. I had to miss that one. It's unfortunate, but family comes first, as you know. So yeah, I mean that is the micro is what gets me going, because if we all get our gardens nice, the whole city looks nice. So that's my philosophy, and that's how we need to. So thank you for doing
Right.
this.
Thank you so much. I'm so honored. Right. Thank you, Ji.
Pleasure. Would really request you to stay back until the question and answer session, because
I'll do that.
I'm sure the participants I can see that even now there are 93. So we hit 100 at one point. I think that is the highest we hit. I actually captured it and posted in the Facebook by this time already, because I think it's quite a historic moment for ICF activities. And everyone, every stakeholder. That's why it's not just doctors' conference. It's conference for everybody. Everyone invested in a child's welfare must know about this. So that's why it is. So we would like to answer everybody's question and answers also, but without seeing how we do it, which Jewel Chakraborty is going to tell us about, and Megha is going to introduce Jewel. None of this actually mean anything, because these are big words otherwise. So from macro, we want to get down to the meso and micro at the moment, and none other than Megha, who is going to introduce our key speaker, who does it on a day-to-day basis in our work with all our children with special needs, and none other than Jewel Chakraborty. And over to you, Megha.
Thank you, sir. So I would like to introduce Dr. Jewel Chakraborty. He is a pediatric physiotherapist and has an experience of over 21 years in the field of physiotherapy and disability care. His specialization is in neurology. He is a dedicated team member of Child Development Center of Apollo Multispeciality Hospitals, Kolkata, and is one of the founder director of Navjat Child Development Center. His expertise and commitment in advancing development and rehabilitation services highlight his topic ICF and its application at CDC AMH or Navjat Child Development Center. Over to you, sir.
Yeah. Good evening to everyone. Thanks, Dr. Elizabeth, Dr. Gurpreet, and Dr. Lisbeth for your informative session. So you have already set the stage and you have already briefed the most of the part of this ICF thing. So I'll be just dealing with the very basic thing, basically the how we do it. Just for the sake of the audience, I'll just go through my whole this presentation, so that what we actually means about the ICF will be betterly understood. So we know that international this classification of functioning, disability and health is a classification of health and health related domains, and it's a WHO, World Health Organization, framework for international standard to measuring the health and disability at both individual and population levels. Can you see my presentation?
Yes, we can see your presentation.
Yeah. So it provides actually framework for the comprehensively describing a person's individual functioning profile. So, and it turns helps the better understanding of the person's specific needs. So this is how actually this ICF has come to in existence, but it started in 2001. But it started, the whole activity has actually started in 1971, and gradually over the period of the years and decades, then the current that ICF model has are in existence. So what is the aims of the ICF? So the main aim of the ICF is to establish a common language to improve the communication across the discipline and sectors. Very much mistakenly, actually, people think that ICF is as an assessment tool, but it's not an assessment tool. It's a platform where we amalgamate all the other assessments so that we can describe the person's functionality by a common language. It is to provide a systemic coding scheme for the healthcare information and systems, to provide a scientific basis for understanding the health and health-related states, outcomes and determinants, and the data comparison across the different countries, healthcare system and services. As very first session, Dr. Elizabeth has mentioned about the biopsychosocial synthesis. So here, whenever we talk about any kind of a health-related condition or any diagnosis, that diagnosis never alone is not enough to describe the day-to-day problem the person is facing in his life, in his society, and by and large in his surroundings. So if we take an example, this is Mrs. Smith. So Mrs. Smith has a rheumatoid arthritis. So because of that rheumatoid arthritis, Mrs. Smith has impairments in body structures, like we know that that it can be the deformity in the joints. His body functions are affected. She has pain in joints. Then the limitation, that is limiting her activities and restriction in her participation, like she is not able to use her hand for taking care of the others. And all these things actually that pain and that non-using of her hands and other that activity and participation are influenced by the humidity in the environment. So here by this you can understand that this functioning and disability, one has to go beyond the diagnosis of health condition or disorder or disease. So this ICF is important to improve the communication across various stakeholders. So whenever we are dealing with any condition, so or where any individual, so that it's not only about the one person is taking care of that particular health problems or the disease or disorder. So there are the multiple stakeholders are involved in total. So ICF is acting as a common language for those stakeholders. So there are the patient and client, then there are the health personnel, then there are the caregivers, then there are the health and human service agency, and there are the insurer section. So all these stakeholders are working in a tandem. So circling this ICF thing. So the ICF is needed to improve the interprofessional communication. So again, so we need the documentation from the physician documentation. There are documentation from the nursing. So the physiotherapists are involved in the treatment and multidisciplinary process. Occupational therapists are also involved, and the psychologists are also involved in the whole documentation. So if there are a shared language which is common for all the professionals, so that will direct us to a single goal to improve the functionality of that particular person. So here that person is a Mrs. Smith. Again, this ICF is needed to improve the communications across the levels of care. Like if we take an example of moving around the using equipment, if we talk about the wheelchair or the if we need a parking space in a majority of the places, then it has to be from that policy level. If we need that training, so we need that from the service management level. And if we need from that individual level, then we need that treatment, like there has to be the adequate healthcare professional are available to treat those people. Now in the policy level, the regulations about the accessibility of buildings and availability of parking space for the persons with disability. So this has to be done from the policy level. This planning in adequate resource for mobility training program, this has to be done from the service management level. And this working with the patient or client to train that mobility using worker, it has to be from the individual level. So again, so ICF is a common platform for all these activities. And this is the data collection, like improving the compatibility in the disability data. So in this, you can see that there is a global disability prevalence estimate. So all this research activity to doing the research activity to gather collect the data, we need that ICF. We can use that ICF. These portions are already discussed, so I'm not going to in very detail in this discussion. like these are the needed for the disability report and all. So we need, so they have actually used the ICF to collect all these, address all these issues. So to enhance the description of health condition and impairment with information, focusing on learning and development, we can use ICF. ICF used to support continuity during the transitions from one education level to the next or into the subsequent work. ICF bridges disability and curriculum-based information as well as clinical and educational information. It serves between the bridge between the assessment focusing on the health development, curriculum and social dynamics. And it can be used to identify the participation gap. So where the person is getting affected, so that also we can determine, and based on that we can determine the goal. So we use this ICF as a clinical tool also. So I'll just show how we do it in our place. So this is the basic introduction of the concept Dr. Gurpreet was mentioning. So these are so here the individual level, we are dealing with this health condition and the disorder thing. So there are three portions. One is the body structure, body function and structure, then the activity, and then the participation. And all these are guided by this contextual factor. These contextual factors has, one is environmental factors and another is the personal factors. Again, if I take an example of that Mrs. Smith, so Mrs. Smith had that problem of rheumatoid arthritis. So this is the problem at the individual level. Now this is affecting her body function and structure because she is having pain and the deformity in the joints. So joint pain. So the activity she is getting problem is that buttoning coat and taking care of the grandson is her participation. Now, once we have changed in the environmental factor, once she is receiving the medication, that medication actually reduces her joint pain. So, and gradually her body function is improved, which is helping her to taking care of buttoning the coat and taking care of her grandson. Here I just mentioned about, though this personal factor thing is still in a developing stage where we are doing the coding and other things are not in existence right now. But we can think that this motivation can be the other thing that is leading Mrs. Smith to taking care of her grandson. So these are basically the different codes. This we can get from the ICF online. If we browse ICF online, so they have ICF book in a total, and we can get all these details from that book: the body function, body structures, activity, participation, and all these functions, all these structure have a different codes. So body functions have been designated with B. Activities and participation are generally designated by the D. Body structure is designated by the S, and the environmental factors are coded by the E. And personal factor, there are no separate coding for that, but that personal factor is coded by the S. So if we see that ICF category, this red book, this is basically that ICF document. It has that, you can say, the Bible for the ICF. It has everything, all the codes we are talking or mentioning. If we see the body function, there are total 493 codes. If we talk about the body structure, there are 310 codes. If we talk about the activity and participation, there are total 384 codes. And if we talk about the environmental factor, there are 253 codes. So all these codings are describing the human function, body structure, environmental factors, and the person's participation, activities and participation. If we go further details, whenever we talk about any coding system, like here we are coding about the that particular thing, that domain, like structure. So there will be the codings will be there, and after that there will be some qualifiers. So this we need to understand these qualifiers, because without the qualifiers, this ICF coding is incomplete. So there can be 3 to 18 codes may be adequate to describe a case with a 2-level precision. So if we go for that in the coding section, so like those are the qualifiers. So if the qualifiers like 0, so that 0 means basically designating there is no problem in that particular individual. 1 means there is a mild problem, 2 means moderate, and then go on severe problem, complete problem. And there are 2 more section is available. That is, one is 8, which is basically the information does not suffice to specify the severity of the problem. And the 9 is that inappropriate or not possible for the apply the code, or that not applicable for that particular person and at that point of time. So these are the qualifiers in the body function area. Now, how do you use this ICF in our clinical practice? So whenever we are talking about the practice, so we are dealing with, especially in our center, we are dealing with the pediatric population. So we know about the person or the child, his demographic details, the child's name, age, sex, and whenever the child is coming with this, so there will be some sign and symptoms, whatever the treatment the child is getting, and the identification of health condition based on the assessment focus of pathophysiology of the condition. So we do various kind of assessments for the particular child. So those will be those we can code here. Then what are the body structure or faults? Like if we have any radiological examination or anything, if those are showing, if there is any changes or morphological changes in the brain or in the body structure, that can be coded, and the altered physiological functions of that body structure. This ICF coding, we generally we can do in a 2 methods. One is that there is a rehab solving problem. That is a Steffner et al. Has provided one method. So for the cerebral palsy, I'll use this example. Like there is a case of the child name is RD. He is a 6-year boy. The diagnosis with the spastic cerebral palsy, the child already had the bilirubin encephalopathy. So from the history, we got that the child is born prematurely in the 34 weeks C-section, and there is a history of delayed birth cry, and there is a history of kernicterus and seizure. So this is that Steiner et al. So this is the rehabilitation problem solving thing. So here we can see from the patient point of view, these are the like difficulty in speaking, weakness in both arm and leg, abnormal movement in both arm and leg. So these are the parental concerns. So because of this problem, the child is having problem in difficulty in bed mobility, dependent for the daily living activities, and difficulty in using the both hand. Because of this body function problem in the body function, the child is not able to go to school independently. Child is facing difficulty in reading and writing, and unable to sit and stand independently, and difficulty in grasping. So the child actually received the Botox injection, and these are the areas we have converted from the parental concern in the ICF coding, like the articulation, then the basic cognitive function. So these are the body function coding, control of voluntary movement, and these 0.1 or the 0.1 you are seeing, these are basically the qualifiers. Means in these areas, the child has the minimum problem, mild problem, but in the articulation level, we are seeing that this problem is in moderate domain. When we have assessed, and after doing that assessment, we have transferred those assessment in this coding system. So the child has difficulty in popping, changing basic body position, maintaining body position, caring of the body part, dressing, eating and drinking, and all these things have been coded by the D, and these are the different code are describing the different activities. And if you see the qualifier, this qualifier is basically telling us about the level of difficulty the child is facing, and same here in the participation. So the goal for the rehab goal was the hand use. So the rehab goal was the hand use. So these are the things we can see that after doing the treatment, we can see that there will be changes in those areas. So this is the one method we can use, which is a rehabilitation problem solving method. I used to actually practice it in the very beginning when I just started practicing the ICF in our center. way back to 2017, 2016, 17 actually. So we had and I should means I'm indebted to Dr. Anjan Bhattacharya. He is the first person to actually introduce me to this ICF thing. And you must know that he is actually pioneering he is the person involved in the pioneering WHO cerebral palsy ICF corset thing. So these are the basic functions we actually seen. So for the audience, like these are the body functions, body activities, and the environmental factors we have mentioned in that rehabilitation problem solving form. Now there are the ICF core sets. So these ICF core sets basically facilitate the description of functioning in clinical practice. So these ICF core sets are nothing but that there are all codes I have mentioned, like there are 230 or 500, there are different codes are there. But for that particular one condition, what are all the activity, what are all the body function need to be collected in a particular one domain. So that is basically the core set, and which can describe the condition of that particular child. So this is that ICF based documentation form. If we browse to ICF International Classification Function in Google, and we'll find this documentation form. And from that documentation form, you can see there are different items are there, like here it's energy and drive function, emotional functions, and just as an example. So once we go to this documentation form, so based on available data we have, we can do the coding thing here, and this coding will later create the profile. So that I'll show you next. Like the next our case, the next case study was it was a child. So the child name is MP. He is a 5 years boy again, and these are the data we had. And the parental concern was the delayed speech development, but now talking meaningless. He has a poor eye contact, the hyperactive behavior, the behavioral issues, and some sensory issues. So in the assessment, we have done this kind of these assessments for this particular child, and from those assessments, we derived there are some diagnoses. Now you can see that we have used Griffiths, then ADOS2, ADIR, SPM, EC Connors. So these are the assessment we did, and there are some impressions we got this from. Now, if I talk to a person regarding to a layman, or even if a parent, that your child has some sensory processing disorder, so it does not give any glimpse what the child is actually facing at his or her functional level. Or if I tell about the child that your child has a autism spectrum disorder, and that is very high, or high autism, low autism, mid autism. So there are number of kind of autisms are there. But what actually means for the parents, and what actually means for the in the society level, so that is the basis of this ICF. It gives us that particular profile of that particular child. So after getting all this data, so this amalgamation, we have done this coding. So this is the functional profile of MK. Just by looking at this profile, we can see so these are basically the qualifiers we are talking about. So these qualifiers we have linked into that impairment thing. So more the graph is on your right side, means the more the graph is bigger, bigger the problem is. If the graph is coming towards the mid section or towards the zero, that means those are the areas that the least affected, or the child is having the lesser problem. Now, if you see this, these are the body functions for this particular core set. If I mention, like here we took actually the brief core set of the autism spectrum disorder. These core sets are available online in the ICF this website, and these are free to all the professionals can use. Once you know how to use it, then you can do this assessment very quickly. Like we had all this information, and we have converted those information into this particular documentation based form that I have shown you right now. And after that, so this is the profile of the MK. Now this child has received multidisciplinary treatment for almost 6 months, and after the 6 months we have again did his assessment, and we got this profile. still that parents have some concern that the behavioral issue is not going for that particular child. So then you can see, if you go to the previous slide, you can see there is these are the environmental factors. So this the lighter shades going toward the left side is basically the facilitator in this plus signs. And if we see the immediate family and the societal attitude and social norm, these are the area actually working as a barrier for this particular child. And these three things still are working as a barrier for this particular child after treatment also. So if you see the next one, we can see that the graph is much nicer than the previous one, because the child is improving all those domains. Still the child has problem, but the areas our child is not improving, these are the behavioral issues, that impulsivity and those things actually. And we found the reason being is that immediate family, the behavior of the parental understanding, poor parental understanding, not compliance and other things, and they are very much go by that social validation and other thing. Because of this, child was suffering. So this is how we can use the ICF in our clinical practice, day-to-day clinical practice. So these are the references from I received all these. I used all these references for this presentation. And thanks for listening. So if we have questions, we can discuss now.
Yeah, thanks, Joel. Thanks for making it so lucid. I think this is one of the main reasons we wanted to actually hold this CME, that how we can do it in real world. Like how do we do it in our microsystem? And our mesosystem is that our healthcare, our child development centers in Kolkata, and we have two, one in Apollo Hospital and one in Salt Lake. These child development centers, as a mesosystem, as a organization decision, we are using it routinely now, because we toyed with this idea over a period of time, and then gradually found out about the values. So I'll be talking about the values. I mean, why we thought that we must do it. But again, I think we will share something that Joel has mentioned, and Megha had quite interesting ideas about what we should do about it. So over to you, Megha, and then I'll probably share my things. Yeah, okay. So please to stage well, because we'll have to answer the queries that will be coming through later.
Yes, so we can do a lot of things as of now, like since 2 o'clock, we have listened to Dr. Elizabeth, Dr. Lisbeth, Dr. Gurupreet, and then Dr. Joel as well. And in the middle of everyone, we have heard Dr. Anjan as well. So since morning, it has given, like for me, it has given a lot of scope, like where we can think to work. We can like start with the training programs, because if we want it, like Dr. Gurupreet mentioned about research, like first we need to start doing the research. So before doing the research, I think we should know what ICF is properly and how to do it. Then only we would be able to use it as a research tool in research. So that can be one perspective from where we can start, like training properly all the people. And I'm sure like 100 plus. And as you have mentioned, we had more than 100, but Zoom was limited to 100, and rest of the participants were directed towards the Facebook link. So they were there viewing our talk. So yeah, and yes, we have a lot of research opportunities as well. We have collaborations. Already Dr. Gurupreet has done at Mohali, and even we at Navajata Child Development Center is also involved in a lot of research nationally and internationally. And a few of them has already been presented at European Academy of Childhood Disability from past many years. So yeah, these are my perspectives, my pointers from where we can start.
Good. Okay. So now I need to share my slides. Can I do that?
Yes, you can.
Okay. Thank you. Right. Let me share screen. Good. Okay. Can you see my slides?
Yes, we can.
Okay. Now, just before I do that, I need to make sure that video is shared as well. So where do I get that?
When you will click on the share,
Mhm.
before the windows are popped up, at that screen only down, you will see share audio.
Okay, let me start and then we will see how it goes. You
Sure.
tell me if you can't hear me. Yeah, so I have already been introduced. So I'll move on to the Kolkata development model first, because you know the context of ICF we need to understand, and because also Dr. Gurpreet has mentioned this, you need to know what is this that I am trying to say. So if you cannot hear it, it won't mean anything. So please let me know if you can't hear it.
We cannot hear it. At least I cannot.
Okay, so I'll now have to again try to share the audio. Where do I get that? That's the thing. Share screen.
Yeah, in that window only, just pause for a
Ah,
second.
ah,
Yeah.
got it, got it, got it, got it, got it.
Of parents through a standard structure universal
Perfect.
intervention called Kolkata Development Model. The author is Anjan Padjaman from India. I don't know if I say your name properly.
I'll just call the presenters because we have got a team who will present. Shreya Ghosh, who was our intern and then now is a psychologist who will be doing the presentation, and her teacher, Shreyoshi Bhattacharya, a professor of Calcutta University. So over to you.
Good evening, everyone. I'm Shreya from India and I'm a psychologist. So the title of my project is Lived Experience of Parents through a Standard Structured Universal Practice Model of Intervention, the Kolkata Development Model. What is this Kolkata Development Model? It's an universal care pathway. It's standard, and it is for any special needs children of any degree of severity and of any age. This is what the schematic representation of the Kolkata Development Model. Let me take you through this. Kolkata Development Model, the first thing or the point of contact in the CDC is through referrals from OPDs, followed by referrals from communities and from NICU, other general movement assessments. After that comes the initial contact with the developmental pediatrician, followed by an intensive parent training program of minimum 7 days, followed by which the children or the child goes through screening, followed by routine health checkup, standard assessments, and then the multidisciplinary therapeutic intervention. During this standard assessments and multidisciplinary therapeutic intervention, a goal is set, and after that multidisciplinary feedback sessions are there. What one of my fellow presenter has presented in her presentation before me, that there where the therapists do not communicate with each other. This is the solution for that multidisciplinary model. So this whole loop of screening, standard assessment, multidisciplinary therapeutic intervention and goal setting goes on and on when a child shows some improvement or in an intermittent time limit. And the end, and by the end, whatever we are doing through this or we are going through this is because we need to ensure that the core needs are met and followed by the discharge plan. So there are a few outcomes of this Kolkata development model. 380 children with special needs out of 446 were successfully included in the mainstream schools after going through this Kolkata development model intervention. 15%, that is 66 out of 446 children who fail to cope with the mainstream curriculum, children who have severe afflictions or familial social issues of extreme nature. Moreover, the successfully included 85% have done it in an average time period of 8 months only. The 85% were not just children with mild or moderate afflictions. More than half were severely affected at diagnosis using internationally validated standardized assessment tools like ADIR, ADOTS, Griffiths, Bailey's, Corners, etc. Parental engagement, a very important aspect of Kolkata development model.
Okay, I think the reason I stopped sharing is that, otherwise my own audio was not getting shared. So I'll share again, and I'll now tell you about what we do when we actually do our ICF course set assessments. So we'll take some examples. Before I talk about the example, let me tell you about the story, why we embarked on doing this. This one is ICF course set on autism spectrum disorder, but the pioneering WHO pediatric course set was established in cerebral palsy, in which I was involved. So that uh, time we had a child with cerebral palsy in our center long time ago. When the parents came from rural part of Bengal, but they were quite rich. In their village, they were quite a well endowed family. The child used to come to us, and we were using the Kolkata development model, and we were getting successes in many cases. But this particular child was still not improving as much as we thought he should. Where was the problem? We are doing all these assessments, internationally validated tools, and we are finding out that there should not be no particular reason why this child would not improve. So parents were thinking that we needed more technologies, and they were consulting others like automated motorized wheelchair. In those days, those were very, very costly and was not easy to import, and all that. It was not that available. But where would he use it in the village? Having a gadget may not be the solution if it is not appropriate. They had a big house where the child could have mobility. So these were initially thought of, and huge amount of investment would have been made in that stage. At that time, we were not doing ICF course sets routinely, but we did it at that time before we decided on relocating families' resource to buying a lot of sort of gadgets. And where we found out the problem came? The problem came in activity and participation group, where we picked up only one assessment that would have given us that, because there were no indication that there was the problem. The problem was that the child was about 8 years of age, with a mental age about 3.5 years of age, where he started missing his friends because in the village other children avoided him. Even parents, even in their social milieu, where a lot of people came of their own sort of, background, well-to-do families of the village. Even their children were instructed not to actually, play with this child because, he had disability. Once we started buddy scheme in our center, in our place, things changed very, very dramatically quickly. Within 3 months, child was actively participating in many things. Within 6 months, his mobility has improved dramatically, and within a year, he was working semi-independently, like GMFCS 4. So in those kind of scenario, we have realized the value, and when we were started doing things with autism spectrum disorder, we understood the value of core set. Like this is a child who is quite significantly affected in his functional profile of body functions. And in his activity and participation, you can see that things are not dismal, but there are areas which are really affected, like, basic interpersonal interaction, complex interpersonal interaction. So quite naturally, we will dive in with the child's improving the child's interpersonal interactions. But we needed to look at the external factors, environmental factors, right? If we see that his immediate family right now, their attitude, at the extended family and their attitude, and the people around in the positions of authority like school and neighbors and acquaintances, they're all having a negative thing about him. How are we going to change this without changing that? And because by now we are quite adept, we have first focused on the family and the surroundings and teachers and things. And once that changed, we didn't have to do anything particularly for this. So our resource was properly multidisciplinary allocated, giving the benefit to the child that he needed in his functioning. Similarly, this is another child who is severely affected. You can see a lot of core areas are affected in his body functions. And his school education and engagement in play and learning to read, these things were affected. But we would have wasted a lot of energy on the families if we did not have his environmental factors. So this is the way we knew that there were no barriers in his environmental factors. These are per se areas where we need to focus. For example, for school education, this child will need special educational need teacher, like, a special educator will be dedicated to this. For learning to read, we need things like, say, scanning pen, which will read it for him, the gadget. Otherwise he may not improve from so much barrier that he has in his primary function of learning. So this is where ICF core sets really come handy. So another example where you can see that the child does not have so much problem with his core features of his body functions. Like the brief set were only picked up only few areas where there were problems. But in his activities and participation, his focusing of attention, his calculation, and this sort of set of areas were really, really affected. So when we look at his activities and participation, we could easily see that in his engagement in play, P refers for performance, C refers for his capacity, which is matched in most of the areas you will see. Right? Everything almost. Undertaking multiple tasks is only area D220 where his participation is less than his capacity. Similarly here, it's quite obvious that his engagement play is quite bad compared to the capacity he has. He almost has no difficulty in participating in engaging in play, but he's not doing. So what we will do is, we will look into these environmental factors and see that his extended family, people in position of authority like in school, and friends, attitude of friends are really his barriers. So we introduce buddy scheme. We become their teachers first before the child improves, and we work with the family extensively to remove his barriers so that his capacity, his performance matches his capacity. Our last example. This is again another child who is not severely affected in terms of his body functions in his autism. So we can see that, his communication is really suffering. And you understand that, if somebody's communication suffers in autism, you need to know whether this is a primary problem or secondary problem. He's not really speaking. I mean, his even capacity is not all that developed. Non-verbal is affected, verbal is affected. So we looked at the things that are affecting him. So, you know, the problems are in his macro system, right? Other areas are really affecting him very badly. So unless we write to the counselor, unless we write to you know, the people around him, you know, they are all very helpful, but the systems are pulling him down. You know, he's not getting the services that he should get inside the school to develop his communication. So he probably needs augmentative communication system in school. And this is how we can actually understand how to do it, because, you know, the healthcare professionals, the educational professionals, the authority, community and neighbors, they are very helpful for this child. But if the school doesn't have a system, how are you going to make this child speaking better? And you know, you know that his core features are not that all that much. So this is how this happens. And I would invite one of our colleague over here, so that, you know, she can share her experience about her use of ICF core set. So over to Lopamudra at the moment, and I will stop sharing my slides. Megha, Lopamudra,
Yes, sir.
anybody?
Yes,
Yeah.
sir.
Yeah,
Good
Lopamudra
evening,
is here.
everyone. Yes, just give me a moment as I share my slide. Hope my slide is visible to everyone.
Yes, it is.
Yeah. So, thank you so much, sir. So, learning what ICF is and how it can be effective in the intervention as well was something very enlightening to me. And I'll just like to share a few experiences in the form of case studies that, you know, made me feel very excited to be rather in learn more about ICF rather. And I'm quite much interested in the research for the same. So yeah, let's go about with this one. So I was doing a family therapy one day, and the child's parents of this particular child's parents, they came up to me and they were like, "Ma'am, we are facing a lot of trouble." It's like, okay, fine. So how can I help you? And they listed a set of concerns. It's like, "Ma'am, these are not going away." It's like, okay. So there are some checklists and checkpoints, and like, are you people doing this? Yes, I'm doing this. Are you people doing that? Yes, I'm doing that. Are you people doing this? Yes, we are doing this. So everything was tick, 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 tick. Everything was all fine. I was quite taken aback. I was like, what's going wrong? That the child's treatment isn't working as it should have, because this child, he came in an early intervention phase to us. So the treatment, it should have worked very effectively for the child. So then all of a sudden, like the Archimedes came upon the Eureka moment, I came upon the ICF moment, and I asked them for their ICF report, and this is the report that you are currently seeing right now. So as you're seeing in the activities and participation, very rarely we get cases where the performance and the capacity are equally impaired or not impaired as for this child. Okay, so when we get cases of this sort, we actually understand that, you know, where are the difficulties within the child with the participation and the activities that we are treating. So then I was like, okay, fine, the child is doing well in this stuff and all. And then I came upon the environmental factors. And here, as you people are seeing, one of the barriers that the child is having is the immediate family. So when I showed the parents this report, they were like, okay, so are you trying to say that we are posing a barrier in our child's treatment? So I was like, it's not me who's saying it. It's the report which is stating it. And then the discussion headed forward, and we actually came upon certain points which was posing a barrier in the child's treatment and was coming from the child's microsystem. And that microsystem was rather affected by the mesosystem of the child and the macrosystem as well. The societal attitude, the social norms and the ideologies. The parents, they were having a difficulty in their own life, which were getting displaced upon the child's life, and they themselves were not aware that this was becoming a barrier in the child's treatment. So on discussing this report only, the parents, they were, it was an eye-opener for them. And since then, the child is improving really, really greatly. Even the parents have reported the same. So similarly, another experience, and this was rather a retrospective learning for me as a psychologist, as a professional. So this is a profile of a child who, as we are seeing, are having quite difficulties in a lot of areas. So this child's Griffiths was planned, the developmental assessment Griffiths, it was planned, and it was planned after a festival. Okay, after a festival, this child's Griffiths was planned, and the child's health, it fell weak, and they were unable to show up on the assessment day. Later on, when I was actually trying to understand that, this is not usually the case with the children who follow the Kolkata development model, who are under the treatment process following the Kolkata development model. So it struck me, and again, I came upon the ICF report. And as we are seeing over here, the immediate family, the extended family, the interpersonal, I'm not sure if you're able to see the top of the slide, but under the environmental factors, the immediate family, the extended family, and under activities and participation, the basic interpersonal interaction and complex interpersonal interactions are of a huge difficulty for the child. So just to give an overview that what happened in the festival, during the festival, the child was fed a lot of things which were not recommended for the child. As a result of which, the child fell ill. Okay. So the parents, they also didn't understand as to why it happened. So while we sat for a discussion, because it was really a distressing situation for them. So when we sat for a family therapy and when I was addressing the distress, so I discussed the report with them as well. And they were like, okay, so these are the factors which are causing a difficulty in my child's treatment, a difficulty in the development of the child, of my child. So I will stop sharing my screen right now. Yeah. So as I discussed that ICF as a tool, as a learning tool for me, has emerged to be something that is providing to be an interventional strategy for not only the development of the children, but also the development of their parents, which are providing a huge support in the development of the children. So thank you, sir, for providing me with the opportunity to share my experiences. I hand over the stage to you.
Thank you. Thanks for your experience, because how Jewel has mentioned, how you have mentioned, it's about doing it at the micro level. And that is going to gather the evidence, that is going to gather the data for our health policy makers to work at the macro level. But at the meso system, if your organization doesn't support you, you can't do it. And that is why we would request all the organizations that have MOU with us, and all the organization, people from different organizations who are actually listening patiently to this long discussion today, please think of using it. Oh dear, Elizabeth has to go. So I would suggest let you have one or two queries to Elizabeth. She has shared something. Elizabeth, if you have got 2 to 4 minutes, anyone, if they want to ask you anything, they will just ask you something. Is that all right?
2 questions.
Yeah. Okay, 2 questions to Elizabeth. Anybody? Even our other participants, other speakers.
But I just want to tell you, which I posted in the chat, that we are now making this digital application to be transformed, so we can discuss how to go further on that. Because it's
Yeah.
exactly what you are showing, the indicators and so on.
Yeah. So also we would like to get Gurpreet into this, so that we can actually formulate a strategy, so that we can really be at the cutting edge, and no less than that, from the very beginning. I mean, as Elizabeth is saying, in India we are doing a lot about it. It's still a huge country to make all these things integrating. We need everybody's best foot forward. So yeah, Gurpreet, your comments.
Yeah, absolutely. But as Megha pointed out, first we have to start from that basic, first we have to have the understanding of ICF. And from there, I think we need to do it on a war footing, because we have a long way to go. We have learned from our colleagues who have been there in this, for decades now. I think we have to provide the policy makers with some data, proper data, research-based evidence, and we are lucky to have our global partners with us, and I think we all can do it with their help.
Yes, that's the spirit. That's the spirit. That's why we are still at it. So yep, there is a question, I think. What are the notable changes that come with implementation of the ICF model and interventions? Yeah, that's a good question. I think we all will take it. But first, Lisbeth, what are the notable challenges that come with implementation of the ICF models and interventions?
I think there are 2 different things: the ICF in itself, and what you want to define, and not making 2 big core sets, because if you have a core set of 12, it's already a lot for parents and also for ourselves. So restrict core sets, and then we can make them exchangeable. That is not so much of a problem. The problem is, on the other hand, countries have not adopted the ICF as an interoperable coding. I don't know about India, but in Europe, I have to really push, because not many doctors know about digitalization, and also not many doctors know about the ICF. So we do it now from patient perspective, and luckily in Europe, patient voices or client voices are heard more and more. So that is how we try. So that is how we would like our Swachman patient group, our parent group, have the ICF available on their cell phone.
And I
Great.
have a quick suggestion also.
Yeah,
I think we have to work on developing the language, because, most of these tools, these are in English. So if we translate, the use of ICF, proper language, the questions which we have to formulate, that will be a big task, the local languages. And that is how, the data will be affected, how we are putting the questions, right? So language also will be a barrier for us for implementing these tools. We need to think about that as well. Yeah.
And that's a research question, isn't it? That's a research question. So yeah, opportunity for research.
I think the big advantage of the ICF is to have numbers, and which are codable. So if you put D730, for example, and then the indicators, it would be exactly the same as in the Netherlands. The computer does not know about the languages. That's the big advantage. So once we have it coded, we agree on the code that we use in which case, then the coding speak for us, no matter what language.
So before you go, I will leave you with two fantastic messages. One from Sweta Saha. She says, I also want to join and work with you all. So that's one.
Very good.
Great. Of course, you are most welcome. Please stay in touch. And another is from Meeta. Sir, every state we have to translate to their vernacular language. Just for your information, everybody's information, we have taken part in one of the local language validation of Western developmental assessment tool. From Navajatak Child Development Center, we have just completed one with a big global international group where we have translated in many Indian languages. One is Bangla. So, yes, we are very much in favor of that. And that is probably what we have all been working together so that this can happen one day in India, and that day is today. So, it's happening. And tomorrow is our World Cerebral Palsy Day. So what better? We really need to take this forward to give our kids all the best tools that are available, easy to do, so easy to do. All you have to do is to learn. These things do not cost anything apart from cost of learning. That's it. Once you learn, you can deliver and translate some benefits which otherwise you will not be able to. Like, the examples I was telling you about. These were despite of our clinical eyes and clinical thoughts. We could not pick these things up. ICF picked it up for us. So please do not rely only on one tool, that is clinical tool, as we do in India and many third world countries, I would say. Make use of all those tools because these are free. I mean, WHO has made this free online. So our connectivity needs to be up on speed, not like how we started. So those are the issues that we have to work on, and we need to talk to our policymakers for that. Why this is so important?
Bye.
So yeah, bye. Thank you, Elizabeth.
Thanks, Dr. Elizabeth.
Pleasure. See you again in our next thing. Good, because Elizabeth is such a wonderful soul that she's there all the time, whenever. So there are other questions. Right. I would be interested in translating in Kannada. Okay, so Prarthana, right. So my question to Prarthana will be, I think, can they come and speak now? I think they can all join one by one. So Prarthana, if you can unmute yourself, we'll start the dialogue with you because we have got a lot of time to talk about. And then when we are done with our questions, then we can take a chitti. So Prarthana, can you join in, or are you from Facebook Live? You can write also.
So we cannot see people who are from Facebook Live. So
But can we hear them?
Yes, we would be able to hear them if they unmute themselves.
Yeah. So Prarthana.
Yes, sir. I am here, Dr.
Yeah.
Anjan.
Yeah.
Yeah.
So you said you'll be interested in translating in Kannada. Like
Yes.
just like you, there will be many. Somebody will be in Marathi, somebody will be in Danish, somebody will be in Odia. In our group, I'm talking about. So for all of them, our interaction will be very useful. So what I would like to ask you first is that, are you attached to any organization?
Yeah, I am attached to a medical college. We are placed in Bangalore.
Okay, good.
So,
Fantastic. So your go-to place would be nearby is the Believers Church because they have a MOU with us. Also, you yourselves from your organization can have that MOU. Megha will facilitate that because if you do it on your own, which research body will come to you and try to do it, right? So you understand, we have to join hands formally. So once we have formal joining of hands, we then allocate. So if we go for a Indian translation, that will be the big project, right? And then we will say, this is our nodal person for Kannada, this is our nodal person for Bengali, this is our nodal group for, Odia, and these sort of things is what I am talking about. So Megha is going to be the go-to person because she is very good in making collaborations happen. She is our MOU person as well. So talk to her and see what works best. So we can even start with our Kannada thing. So we'll start
Okay.
with Bengali and Kannada, and I'm sure with Gurpreet we can do Punjabi as well.
Yes, that will be a great opportunity to
Sure.
get introduced to this ICF also.
Yeah. So thank you. Thanks for your
Thank
question.
you. Thank you, Dr.
Thanks for your
Thank you.
aspiration as well. Fantastic. And yeah, okay, yeah. Somebody's Meeta is collaborating her full-time PhD now. So how can she collaborate? So question is, when is your PhD going to get done? Meeta, if you could now join, unmute yourself and join. Prarthana can mute herself now. Thanks. So what my problem is that, I do not know whether Meeta is from Facebook Live or here. Unable to unmute. So can our technical guy help her to unmute?
I can check. I'll
Yeah.
just check.
Because I think where there is a will, there is a way. So we'll find that way. What is best for Meeta?
I have put forward a request to you, Miss Meeta. You just see if you are getting it. Yeah. I think you can speak now.
And
If
this
you
is the
are
reason.
speaking, then please post it in the chat because we are unable to hear you. This might to be a problem from the mic that you are speaking.
Now you can understand why we have kept such a long time for our question answer session, because most of the time. Yeah. So okay. So I'll say from my end that what are the possibilities that you can have. So my normal suggestion to a PhD who is completing a PhD is that concentrate on your PhD now, because if this is not one of your topic, don't dilute your efforts. Because if you are doing a proper PhD where you are really having to work, we know that in India two forms exist. So if you are really getting your doctorate degree, right? I mean, you are working hard to get it done, then you should concentrate on that because it takes all your energy. That's my experience, right? And if you have spare time, you relax at this stage and have an aspiration that as soon as your thesis is submitted, rest of it you can manage. You then approach us again and you join back. But if your PhD is nearly finishing and you can really now spare time and all that, then obviously you again try a formal arrangement. Like if you are under a university, so there are two formats. One is a professional group. You are part of a hospital or a child development center or a mental health institution or something like that, right? So you try to join in the name of that institution. That will help. Or through an educational body like your university. Even university can endorse single student who can represent the university itself, because these are pioneering activities for India. And every field it is needed. This is not just in medical field. I was just mapping hearts and minds project, and I was just realizing how many areas will have to come together. Yesterday I was in a international meet for karate. So there was a British guy from Sri Lanka who is that teacher who came, and there were trainers from Bangladesh, Myanmar, and other places as well. So there is a huge group of children who learn martial arts, and quite a number, significant, at least 20% of those martial art people were children with some sort of special needs. Some could not speak, some could not really use some of their limbs, and some had body posturing issues. Despite of that, they are all participating. This is an integrative model. So how do we ask them not to participate? So what do? We create professionals in them. For example, in our postgraduate diploma course under the government's university technology, West Bengal University of Technology, We have this collaborative and research program called CCPTR, where Navojatak Child Development Center has started in Eastern India's first postgraduate diploma course in early intervention. In that, we have one student who is actually a martial arts specialist. She is learning how to involve in children with special needs using martial arts without harming them. This is specialization. This is not super specialization. She won't have a degree to act as a specialist, but she will not be harmful when she works in her own world with children with special needs. And everywhere you will have children with special needs, every field. So yes, it is very nice that you are trying to do your PhD as well as join with us. But what we are proposing is what Dr. Gurpreet is proposing, that now we need to do things in proper style. Gone are those days when we used to say, kuch bhi kar lenge, wo bhi ho jayega. You know, we won't go like that. We will do as it should be done. Because as you have just heard, we have actually validated one developmental assessment tool, Western tool, in Bangla, and we found out it to be of extreme use, very useful. So we need to do that, but we can't do it unless we engage with those organizations in proper manner. And through this exercise, the one that we are doing at the moment, let's learn to do that. I remember having real difficulties of Indian medical graduates to join in an Australian DCH program, which was online based, because these doctors aspired to have DCH UK or MRCP CH UK. But if they could not log in, for example, DCH UK is the exam itself is online nowadays fully. So if you cannot manage yourself to enroll in a course where you want to do it, how would you be able to manage the rest? So these are like gatekeeping tests, and I use these gatekeeping tests because I know the situation in our terrain, which we have actually shown both from Pakistan and India separately in two separate WHO regions. We have done the WHO's first validation study in ICF core set using cerebral palsy as a model, which was the pioneering set. The autism and the ADHD courses did not come by that time because we are doing the first one. So yes, research, publication, books, medical education, and Zoom meetings are all being English. We should stick to available WHO software given in English. Otherwise, it will not be sustainable for the time being, Dr. Elizabeth. Yeah, for the time being. But you can see the world is moving around. So we need to do both. We need to really empower our English education. China is doing that at the moment. So yes, empower English education, which is in itself works like an integrative model in language, and we need to. So Dr. Elizabeth, I would really request you to come on and say your thoughts at the moment, because I think you have got a lot of thoughts, and we would like to hear from you what we can do together. Please join and tell us. And then I would like Gurpreet's comment about what you have said.
Thank you for giving me this opportunity to talk. Can you see me?
Almost, but we can hear you.
Okay.
Ma'am, you have to turn your camera.
I think something's happened. I just now
I think
what I've come to tell is now we have lot of tools in disability, like for ADHD, whether it is autism, whether it is a Heinz, whatever it is, we have a lot of difficulty in terms of time. See, when you measure them, of course, we all standardize what we are asking. Translating to the patient is probably the role of either the doctor or the therapist or the psychologist who's doing it. Now, when the data that comes through it, the measured data is probably easy to want to analyze it. It's easy. This is my problem locally. Everybody knows English, but they prefer to converse in the local language. But when it comes to filling a form, the English, I think, would be the best one, because there will always be a healthcare worker doing it with the patient. It is always at the beginning, isn't it? So that's why I said we all need to make first, is as soon as a patient comes, like you have your Calcutta model, we make a etiological diagnosis, find out is any medical things that we can interfere in terms of medication. That's all. Then the rest is all the game of going on to the patient's level and putting the early intervention. So at that point, having a score, this will be the right thing, because for everybody it becomes a common language, a standardized language, isn't it? So that's why I said, if you want to make another set of translated tools, this again means resources and time.
Absolutely, ma'am. But what have to look into the future as well. So
we should take it 1 year at a time, like,
Yeah, absolutely. So for the time being, we concentrate doing things in English because that's what is available. Why waste that opportunity? And then move on. So yeah, Gurpreet, even Joel.
Yeah, I can share my thoughts on that. So absolutely agreed with what Dr. Elizabeth said. The only thing which comes to my mind is, as Dr. Anjan, you pointed out, and even I had thoughts. So when I was doing this mobile medical unit, using them for the screening of tuberculosis patient, we needed, the workers at the grassroots level to be able to converse with these, the presumptive cases, as we would call them, right? And when they have to converse with them. So I'm thinking about going to the grassroots levels, right? ICF language is something which you can go right from the grassroots up to the apex. Very rightly said, it's just a starting stage, one thing at a time. If we start translating now, we will get to it at some point. We are focusing right now on at our institution levels. But then when we go to the ground level, the language spoken by the common person, the symptoms presentation, for instance, as simple as that, eye contact, right? Yeah, whatever questions you put to the families, they may not necessarily be the same what we are using in the Western culture, right? So we have to see what language is there in ICF, what are the commonalities which we use for our questions at the grassroots level, because cultural differences would be there. We have to devise a language which is there. The uniformity will come at the coding stage. The codes remain the same. So in spite of the language, whatever you are using, as Dr. Elizabeth said, Dr. Saitris said, the codes remain the same. But then the questions which you are asking for making that assessment, that has to be different. You can't, no one is very perfect at translating that language. And then if we all specialists sit together and have a translator, start working on that, then maybe we can get to it at some stage. That's my thought.
Yes, fantastic. I think Joel has also mentioned something very nicely. So why don't you, Joel, come on and mention that, because I think it's
So I
important.
think, sir, the basic thing is, the way I think I have learned it, it's basically the first we need to have that basic training, what is ICF coding and how to use that, what are the codes, because many people have asked me, so we have to remember all the codes. No, it's not actually needed actually, because everything is available over the online available. And if we have the even the soft version of that ICF, that book, everything is available there. But what the important is the training part, that very, very basic and preliminary training that Dr. Gurpreet also might be agreeing with that, because that basic training is needed for the professionals, the multidisciplinary professionals, and they have to be aware about the number of these assessment tools are available with us. Now, if for one single or individual, for one particular case, we should not use too many tools, means assessment tools. So there has to be some standard and basic tools that And using that, after that, we need to convert those assessment into that ICF language. So that is that linking thing. So if the child is a moderate, mild, moderate, or severe problem, if we can do translate that in the coding method, so that is the first stage. And because the course sets are available on most of the disorder, at least in the pediatric field, the most of the course sets are available right now. So if we start using those course sets, and from whatever the data we available with us, it's not about, it's like maybe one center is using some or the other these tools or applications or analysis. So whatever you are using, we have to code them. So we need to use them in that profile thing. So once that profile is created, then it is very much easy for rest of the thing. And just Dr. Bhattacharya was showing his example. So just by profile only, we will get to know what the problems are lying in that particular type. So we need not to be dependent on the professional, what they are particularly saying, what parents are saying. So just by that profile, we'll get to know what the person or the child is suffering from. And from that point of view, we can design the treatment and everything. So the basic thing is needed, basically the basic training, very basic preliminary thing, because otherwise ICF become very boring thing. So that boredness will go unless we do not start practicing in regular practice. Once we start practicing, then you will fall in love. Definitely, you are going to fall in love because it will make your life very much easy. It will give you very much easy how when you will talk to your parent, means your patients, client, whether you are working in an individual level, whether you are working in a group level, means in a multidisciplinary level. So your communication with your professionals will be very easy. Your whatever you are reporting to your client or parents, that will be very much easy, and parent will understand, because just by talking, parent will not understand. But so if you are listening something, if you are visualize something, then only that will be very much better. And many times we have seen that particular profile, that the problem is somewhere else and we are focusing at somewhere else. So that focusing, so defocusing, so that instead of that polarization thing, we have to focus it in central. So that central thing will come once we start practicing in a day-to-day thing. So even if, like if I gave a small example, if a parents come to us and they are giving some kind of a concern that my child is having speech problem, my child is a this and that problem. So immediately from that parental concern, we can code those parental concern in the preliminary thing. Then you go for the assessment, then you can means elaborate those things. So that also can be done if you are not using the course set thing at the very beginning. But if you start using the course set from the very beginning, then it's very much easy. And it is available. We need not to have access, because that is most accessible thing. Even all the online means whatever the thing we are mentioning in the this in PPT and everything. So everything is available in the that ICF platform. So we can educate ourselves from there also. If someone has difficulty, because obviously there will be some difficulty in the beginning. So if we start some and those training, I think it's better on-site training, means offline training, because at least I feel it means I can learn much or I can deliver it better in the offline mode better. So where you can have the practical examples, you start practicing filling up those forms, then it will be very much easy. So it's the matter of starting. Once you start, then the gear will automatically go on.
It's actually very easy to do something, and as Gurpreet has rightly said, we should try to train our Anganwadi workers, ASHA workers. That is where we will get the macro data for our disability census, you could say. But Dr. Elizabeth is so right in mentioning that we need to do something where it benefits the patient. So Lopamudra was actually saying that she got startled by seeing that ICF course that actually works because it's visual. It's easy for parents to understand that it's independent of a professional's judgment or opinion. It's really a objective tool. What we are trying to say is that it's very easy to do something only when you get trained. Training is also very easy. It needs either you self-educate yourself. If you have any difficulties, seek help. We are there. What is not acceptable is saying that we can't do it. Means we are actually saying that we don't need any disability data for our children in India, and we are saying that who cares about those children with disabilities? Let whatever is happening, let it happen. So that's why we are saying that we have got the complete solution now. WHO has given us a wonderful framework. WHO has come up with a clinically applicable model. It just needs a little bit of sitting down and understanding it, which can be done online like we are doing it now. Now people are motivated, and we have just seen with Dr. Mita's interaction how important it is sometimes to actually do face to face rather than try online. It doesn't always work. So if we actually do it that way, many more clinicians, professionals like Lopamudra, who is having the splendor of practice opening up in front of our eyes, can enjoy the field of practice. We can really enjoy the field of practice where we can actually collate data on everything patient says. That mera pet kharab hai, I stay in a distance, there is a problem in my house, my local electricity board is not giving electricity. All this comes under one framework of healthcare delivery of the third handle, which has been proven to be important, which is functionality. So we are gone past mortality and morbidity stage. We have come into the era of functionality. This is our first step in that direction. Let's do it properly and make it. So my request to Dr. Elizabeth, as Jewel was actually mentioning, from Believers Church College and from Vivekananda University, from these two educational organizations, and if there is anybody from Gokhel Memorial Girls College, because we all need to join hands together. So would you be able to hold a training session in your place, or we are very happy to get your guys here? You decide. Dr. Gurpreet, Moha Ali, the university or the medical college or the child development center, we can all bring together a training which is all hands on real patients. Kailash, are you trying to talk, or is it just getting unmuted? It seemed like he tried
I
to
think it's
talk.
by mistake.
Okay, all right. But this is what I'm saying. So if anyone wants to come up with any idea, we can discuss it now, or we can do it later again, and we can take an early break. So all our meetings, this 1 hour buffer will be there. Okay. So that's how we will plan it, because what I hate is that we talk about something new and something fresh, and people have ideas and we don't get to share. So don't mind if it finishes early, because we have kept it on purpose knowingly, so that we talk less, we hear more, and we discuss more. Certificate we surely will do. That is yeah. CME.
Yeah. So yeah, I'll
Participation
okay.
in
So
CME.
I'll pay. Okay. Done.
Yeah. Actually, Mega, if you understand, I myself will need it for my CPD folder in Royal College.
Okay, so what I'm going to do is within 24 hours, everyone will be receiving the feedback form. So as soon they will be filling up the form. So then within next 1 week, they would be delivering the certificate online.
Fantastic. So we will just leave 1 minute or so that just to make sure that nobody else has any more questions. But if you do, then your time to ask us is now. So you're having congratulatory note and thank yous, and which are fantastic. Yeah, we would like to thank everybody. So over to you, Mega.
Thank you so much. So again, I'll try to share my screen. I'm successful this time. So Do let me know once you can share my screen.
Anjan sir,
is
can
my
I ask a
screen?
question, sir?
Yeah, please, Dr. Jiju.
Yes, sir.
Yeah,
Hi, sir.
great.
Sir, at this point, has
Yeah.
ICF been incorporated to any of the government programs at this point? Do we have access to, has it been incorporated anywhere, sir?
Dr. Gurpreet, are any of your endeavors involve government?
So it's actually being, I am aware of the fact that for the last 15 or 20 years, this training part of ICF has been going on. Like Dr. Preeti Arun from Grid, she has been the trainer of trainees for this, and she shared with me that of course the training is going on. People are aware of it, but as far as incorporation in the health system is concerned, so HMIS data that is not being done. Uh, Government Medical College Sector 32 Chandigarh, they are using ICF for the mental health conditions, but again it's more of their efforts rather than coming it from the government side. So that's what we are trying to take it up. There's the CBHI, the Central Bureau of Health Intelligence. They are actually supposed to take up this ICF project, and we are pushing it with them also, because as all the speakers have shared, ICF forms the basis for the census data, forms the basis for this disability surveys. It has to come, and with the rehabilitation goal 2030, I think the government will get going with this.
So once it becomes a part of the NFHS, things will be much more clearer as per the data is concerned. So that should be one way of, in some way, if this becomes part of the NFHS data collection, you'll get the whole Indian census coming in, wherein you can work up once the government gets involved. Like it likely said, the ASHA workers, Anganwadi workers, they all have a huge role to play. But unless it comes through the government process, this has a huge scope. We can't uh, take it to the place where it is supposed to. That is one problem. The second thing is the ones which we spoke about. What all are the modules where I say we have modules? I'm basically a pulmonologist, so a pediatric pulmonologist. So my areas of interest are more about asthma and their quality of life. So do we have set schedules in more than just this illnesses, or are we covering a lot more beyond that? Do we have set modules for those also?
So I'm aware of this, that if you talk about modules, I would say, like Dr. Anjan has pointed out, there are a very few core sets available for the core sets for few disease conditions, right? Now, for the respiratory part, it is more for the COPD they have developed, for the asthma also. Those core sets for COPD are studies have been done, with regard to COVID, their application in COVID also. They are not applicable for the ILDs basically, but of course, I'm pushing for the application of ICF for pulmonary tuberculosis cases, the pulmonary rehabilitation part, and that's what we had published. So you have the core sets, and currently there is a study also going on. I mean, the research interest in this developing a respiratory guidelines. So by the WHO. So they are thinking about it. But as far as the modules you're talking about, no specific modules are available. And this is where I say the clinicians, all the clinicians have to say, okay, these are the conditions which we find commonly. These are the, areas, say for asthma, you find these are the risk factors, or how you would assess the particular case, how the child is doing, how the use of inhalers is there. What are the factors which affect most? Those are the things which you can use easily draw up from ICF. ICF has got so many, it's about, I think, Jewel would be able to tell better how many categories are there. Like, 1400 or so. So it's such a wide areas to pick up from that you can identify those areas and then start developing. And I think Dr. Anjan can share how he developed this CP for the CP child, the core sets. So basically you have these core sets coming up, right, for different conditions. And these core sets you can develop from whatever the areas you identify, whether it's the body structure, the body function, the activities, the participation, or the environment. So from there, you can, draw up certain areas and then develop for those disease-specific conditions. So as such, the guidelines for modules is not available, but yes, the core sets for in respiratory medicine, you have for COPD, then you have for the neurological conditions, you have for the musculoskeletal conditions, for the spinal cord injuries and all that. So
Like,
they're all there.
I just wanted to mention, like if you go to that cardiopulmonary core sets are available. So once you go there, so there are like brief section, then the elaborate section, lots of sections are available. So for particular individual or particular cohort of group, so apart from that brief section, you can select from the drop down menu, what are all the additional things you want for that particular cohort of group of patient. So in that way also you can use that core set initially. But the way that Dr. Gurpreet was telling about that how that module can be developed, that's basically the consensus process that Dr. Bhattacharya was involved for that CP thing. And gradually those consensus meeting, but that has to come from, I think, from the WHO level, or maybe from the some central body has to be involved, because then it needs some validation, actually, worldwide validation. So that also can be done. So actually those are the scope for the research areas. If we can work on those areas, the module are not available. So we can join hand from the different multicentric thing actually. So we can join hand and we can develop, and then we need to validate with the, we can check with the central body of the ICF whether these can be means this can be applicable for the worldwide or not.
So one suggestion is we have Anjan sir who's actually done it. So sir can maybe guide us to pick on a course set which is not available and try to validate it in our population as a multicentric purpose. And then we can try to build upon and seeing whether we need more things to add on. That's something which you can look into from a research point of view, sir.
That's what we are thinking about, and that is where people like you will be so in the forefront of this endeavor, because
Yes, sir.
because one of our proposal is, as Jewel was suggesting, that you could either invite our group, like Dr. Gurpreet, me, if Lisbeth could come, Jewel goes, and we have a 1.5 day, 2 day kind of conference in your place. And unfortunately, you guys will have to manage the funds for that. This is the barrier, because that is why we try everything online, but not everything works online. And this is one of them. So this prime moving part, that how we do two things. One is what you have said, is that, in clinical usage, how we can do that. So that is what we will really like to train you guys first. Because as somebody was saying, that until, I think Jewel was saying, that unless we do it, how can we research it? So that would be our first, but you can start planning our researches, because as Jewel was saying, we'll have to involve the ICF research branch, exactly the one that Dr. Gurpreet has gone and done his certification. It is that same branch, I mean, it's that in the Switzerland, the paraplegic, it's the same branch. They will be doing it, but the real experts are needed. There are not many who can create these consensus group meetings in a WHO acceptable standardized format. International standardization is, the burden is quite heavy, and we now need to do that. And if you and I try, why wouldn't it happen? If government tries, wonderful, but it's not trying. So while they scratch their head and come up with a decision, and then the government changes and somebody else comes and starts scratching his head again, in the private field, nobody is stopping us. And if we rely on our human intent, if we rely on that, I never saw money becoming a problem, especially in today's India. I'm talking about the India when we started it. So in today's India, it shouldn't be a problem. It's still a problem for my group, but it shouldn't be a problem, because money should come to good things. It's not happening at the moment, but it will definitely happen. Where will it go eventually? So at some point it will start coming, and we should be planning for it, because it's urgent need. It's urgent need that we do the right things. We have got such wonderful people, so many young people. In this context, I am not, I cannot not share one story, which is from south of India only. One of our, MD pediatric doctor has completed her postgraduate diploma from South, where the developmental pediatric fellowship, IAP fellowship, was there. So she has completed it, and then she thought she will be absorbed in one of the corporate hospitals or government setups or something, and she was not. So she frantically called me one day, "Sir, can you help me with something?" And I called the corporate groups that I know of, because I go there as an examiner. So it's not just Apollo group that I am aware. Including Apollo, I have tried at least 4 big corporate groups, stating my example and saying how we are doing good things. We would want somebody to start there who is a proper developmental pediatrician. They did not say no to her. They said, you can do that job along with these pediatric duties. So obviously, in that case, you cannot do a developmental pediatric practice. So what eventually she had to do is she had to go to UK. She's now at UK. She has dragged her neurosurgeon husband there, who is also having a very good life there. Their 2 kids are there. They were born in India, but they're having a good life over there. And just now she has become a consultant, right? Whose loss is it anyway? Is it her loss, or is it India's loss? So we lose our people right, left, and center through our own endeavor, which should stop. I mean, I'm not saying everybody should stop that. Everybody can keep pushing them away, but there should be some people who is trying to say that let's come and work here. There is a space to work, and you and I and whoever are here, we can make it happen. We have been given a privilege. We have been given an opportunity to do so, and we can do it that way. I think that's the best way to serve the country, if you ask me.
Yes, sir. So we will definitely try to see what is possible over here. In the meantime, sir, you have a wonderful opportunity coming ahead for you, because the 2026 National Pedicon is going to happen in Calcutta. So you are going to have a lot of pediatricians coming in over to Calcutta. So you have exactly 1 year. So the whole we can definitely, once we have the right numbers, we can also connect it with it, not connected with Pedicon, but people are going to be there at that point for at least 4 to 5 days, of which I'm sure many are interested in this field also. So we can definitely club it together.
This is pioneering thoughts. This is what makes things happen. Exact thoughts. You have already thought of it, and yes, it's done. We'll do it that way. Perfect.
Yes, sir. Okay, sir.
Wonderful idea. Wonderful idea. Brilliant. We'll plan it and do it that way. There is no rush, because nobody is doing it anyway. So
exactly.
no rush. We will do it.
In the meantime, sir, we'll keep the thought process flowing, so that by the time we definitely meet up, we have something more solid. And this is brushed everybody's interest. We'll read a little bit more, try to understand a little bit more, so that we have something more solid by the time we come for a meet, sir.
Perfect. So one of the other opportunities for some of you leaders, like senior people, to pop down for a week and we'll get you trained. That's another way.
So we'll definitely have Elizabeth ma'am coming to you, sir. So I would love to have her for a day more and get more information.
Exactly. Tell me about it. How hard did I try? Thanks to Megha, she really liaised very strongly, so that we can have her for 1 extra day.
Sure, sir. Okay.
Sure.
Thank you, sir.
Pleasure.
Thank you for the talk.
Pleasure. Thank you. Thanks for your participation. This is why we are doing, and we will have Swami Vivekananda with us at that point. I'm sure we'll have internal talks. There is a group from Hong Kong who work with pet therapy. So, we are looking into that area. So there are a whole host of things bursting, to help these kids. And you probably are seeing a lot of Facebook and other social media posts where they are really celebrating successes of special needs people. Those sob stories have kind of disappeared.
Very nation stage even now compared to where the West has reached, and we have a lot of work ahead. And at least this point, people are identifying the needs per se, including the people who are practicing. People are identifying this as specialty. One of the futures definitely right. This point is developmental pediatrics, which at this point abroad you have to wait for 1 to 2 years. People in India are not understanding how fortunate they are to get it done as fast how things are running at this point over here.
Exactly, exactly. Absolutely. Thank you. Thanks for those words. And thanks
When you-
to Dr. Gurpreet again for involving Kolkata Development Model to adopt, because now we really can do that because it's a consensus group, global group, and we can push ahead with that. We have presented it so many times in European Academy. We have invited for instructional courses. They are learning from us. We are not doing anything about it. Dr. Gurpreet, thanks to you, we are actually now going to do something about it.
My pleasure, Shi. And I think it should be an eye-opener because everyone has realized that, therapies is one thing which can't go on, on continuous basis. You have to empower the families. And if you, put this spirit in them that they have to focus on functioning, the overall development, not just focus on the deficits, I think they can easily overcome. It'll be good for their life also. It'll be good for the child's life also. Yeah.
Absolutely. And none of this would have started unless Dr. Elizabeth has shared that story with Megha.
Right.
You were trying to
Right.
say something, Dr. Gurpreet.
Yeah, absolutely. Yeah, because, I felt this when I come in contact with the clinicians here. So the developmental pediatricians in Canada, everyone is thinking that, you have to think out of the box. Social medicine is something which is gaining importance. Patient-centered care is something which is gaining importance, right? We don't fix things in chronic conditions. We have to make, lived experience a really pleasurable one. So unless we start thinking about in this framework of ICF, we are not going to get anywhere. Those are my
On
words
that,
for that.
on that account, I would really like Megha and Lopa to share some of the recent stories of some of our kids who has diagnosis, their degrees of affliction, and what is happening to them recently. Just 1 or 2 stories that should make our life so much nicer and make the day our day. Who wants to go first, Megha or Lopa?
I guess Lopa can go first.
All right, Lopa, your turn.
If she's there.
That's the thing.
Okay. Never mind. So till she gets ready, because it's very difficult really to fetch out one success story to to tell. It's really very difficult to tell anyone. So okay. Okay. So I'll
Why is it difficult to tell anyone?
because we have so many.
Exactly, because there's so many people who have benefited, right?
Yes.
Go ahead with your one. Yeah.
Yeah, okay. So, it's not recent. It's about last year, one little child, female child came to us. During that time, she was around, if I'm not wrong, 2 years, 3 months of age. Parents were quite intelligent to fish out the problems early, and they went through the Calcutta development model, starting with our parent training program, which is a unique, one of the unique thing that we do, and which motivates me the most. So they went through all the process that we follow via our KDM, and during the procedure of the diagnosis only, the child started getting better. And currently, she is going to school. She is not coming to us anymore. And she had difficulties with motor, with speech. And after diagnosis, we got to know that she is having ASD, autism spectrum disorder, and some motor disorders as well. And if I'm not wrong, there was a genetic finding as well. But we got the child so early, like it was like 2.3, like 2 years, 3 months. So that genetic loading really didn't took its wrong side, the bad side, and we were able to get the child out of the woods within maximum 6 months. And after 6 months, when we met the parents and when we were asking them, like, what were the concerns that you came up with? And they were all haywire, like they were unable to report properly. And then after that, I remember Joel sir and Anjan sir told them, like, these were the problems that you come up with. So yeah, we record everything. We maintain data of each and everything. So that really helps us because we see parents, after a child is getting better, parents do forget with which problem they have come up. And today the child is speaking very fluently. She will come to me. She will ask me, Megha ma'am, apne ki korcho? Megha ma'am, laptop e kaj korchi? And she will say so many words. And she is going to school. She is doing currently karate. The mother just met me last 1 month ago. She was here at our center just for a minor follow-up. Whenever they come to Kolkata, they drop in at the center. So, like mother said, that she is doing good at school, and they haven't even told at school that the child is having these diagnoses because it doesn't seem that she is having any difficulty now.
Thank you.
Wonderful, wonderful.
I'll just mention about it's a old, it was a old actually case, but they actually had very much family problem also, because father is in a government position, very high position, but he was not very much supportive. So family was kind of in a verge of actually means complete devastation. So there could have you can have divorce and other thing, but the mother was very much actually hold on with the situation, and she fought throughout the treatment journey and everything. But one very fine day, the father came down to Dr. Bhattacharya and started crying. And why he was crying? That he went for some disability certificate to a higher institution where the profession was from higher institution, finding the child is having no problem at all. So the father was telling that I know that how much my child was suffering from. The child has the autism spectrum disorder and not speaking anything and behavioral issues and many other things. Now that father actually came down to our center and acknowledged what the fault is. Now that family has again joined. So it's now that bonding, family bonding and everything is in place. So that is how actually you can say the early intervention, the Kolkata developmental model we talk about, because that child came at a little bit in higher age group, because nowadays we got children in ASD at least at the earliest of 12 months of age also we got the children, because that awareness actually happened in case of ASD if I talk about. And in case of we talk about the cerebral palsy, so just yesterday only we had 2 children for the GM. Again, just right now also I got a call from the hospital that there are another child is there in a NICU. Just everything is fine, but there are some red flag signs. So just they want that GM assessment to be done so that the child can be discharged with some follow-ups or things. So there are stories are everywhere. I believe there will be stories at Punjab also. There will be stories at Believers Church Medical College also. There will be stories everywhere. Just we need to collect those stories. We need to improve increase the awareness so that the parents and that they feel more motivated and they do not stigmatize unnecessarily to the children and into the society.
Fantastic. So see, Dr. Elizabeth, do you see what you have started by chatting with Megha?
Did you hear me? I'll see you next month, the same day.
Yeah.
November 5th.
Absolutely. So thank you. And thanks everybody for their wholehearted participation. Thanks for those lovely questions. I can still see that, in the chat box, there are still messages flowing. Keep flowing them in our WhatsApp group and give our feedbacks, and let's plan and move ahead and do something for our kids. It's
So
highly.
this thing, you people will have discharge summaries, no?
That's the other thing. Yeah.
In
Probably they
discharge,
will eventually. Yeah.
you can start off.
Yeah, you can. Definitely. Mita has said that you should have ICF training session in different cities. And I'm saying, why don't you start?
As you said, training is what is required, probably small groups.
Yeah.
Anyway, we'll think
should.
about, we'll keep it growing, the idea growing.
It's need of the hour. Absolutely. Okay, great. Lovely discussion. So thanks everybody. Let's call it a early day. Thank you very much, everybody.
Thank you,
Wonderful
everyone.
talks.
Bye-bye.
Thank you,
Wonderful
everyone.
interaction.
It was a wonderful
Pleasure.
and a
Pleasure.
pleasant
Pleasure.
session. Thank you, everyone.
Thank
Bye and happy Durga Puja to all of you.
Happy Puja, safe Puja, everyone.
Happy
you.
Puja.
Okay, bye-bye. Bye.
Bye. Bye-bye.
Bye, everyone. Thank you for joining and participating.
Thanks,
Hope we
Megha.
come
Nothing
across.
without you.
Thank
Not
you.
possible
so
without
much.
you.
Thank you to you. Thank you, guys. Thank you, all of you. Yeah.
Thank you.
Thank you.
Thank you. Thank you. Thanks all the speakers.